We'll just give a couple more minutes for people to join before we start. All right, good morning, everyone. Welcome back to our second day of the VNPC Summit labeled Fostering Community Relationships to Improve Maternal and Infant Healthcare Outcomes. Health outcomes. We had a great day yesterday. I would like to thank all our speakers who came and spoke to us about their different fields. We had a host of wonderful presentations. The First Lady of Virginia highlighted the significant impact that Governor Northam's administration has had on policies, budget amendments, and support for numerous programs focused on improving maternal and infant health outcomes in Virginia. We then heard from Jenny Joseph, who highlighted the impact that person-centered care has on improving the care provided to mothers. And when we all band together, we do better by our patients and community. Stephanie Spencer from Urban Baby Beginnings demonstrated that when the community is involved with wraparound services for the patients we are caring for, outcomes are significantly improved, and patients feel well taken care of, heard, and respected by their providers. Mandolin from Postpartum Support VA explained the role that community and members with lived experiences can have when managing PMADs through education. She also discussed providing both virtual and in-person parent and mom groups and volunteering together to improve postpartum outcomes. Deputy Secretary Vanessa Walker-Harris discussed the Virginia Maternal Health Strategic Plan and how each one of us can directly impact change at our hospital, local and community levels to improve maternal and infant health. The team from DMAS provided detailed explanation about the recent policy changes that will help continue the improved care and access to Medicaid for pregnant mothers across Commonwealth. And to wrap up the day, the VNPC announced the official launch of the fourth trimester patient safety bundle, with 18 hospitals being committed to participate in this first round and implementation. I certainly learned a lot yesterday from all the presentations I heard. And even though we'll have a shorter day today, we have a number of excellent speakers from whom I look forward to learning more about what Virginia and its wealth of services have to offer to our mothers and newborns. So great day ahead. Without further ado, let's start to kick off our next presentation. Shannon, would you mind introducing our next speaker?
Yes, good morning, everybody. So our first speaker for this morning is Stephanie Spencer. You all heard from her yesterday. She's going to take off the hat she wore yesterday and put a different hat on today, as she discussed the doulas and their role in maternal health. I will go ahead and share my screen. And we are good. Go ahead, Stephanie. Oh, you're muted, Stephanie.
Sorry, we did that yesterday and I'm the favorite person to do that today. So again, my name is Stephanie Spencer. I am the Executive Director of Urban Baby Beginnings. And today we're going to be talking about doulas and their role in perinatal health. As DMAS shared yesterday, there's going to be a doula benefit that's rolling out for the state of Virginia. And so we thought that it was very important to really set the stage for what that's going to look, what that looks like today, our current landscape today, and kind of give you all some points that you can take away to help us as we move forward. So next slide. So I believe that everybody on this call probably has already heard statistics as they're related to Virginia, talking about the preterm birth rate and infant mortality rate. But I thought it was good to bring this up again, just as a visual to set the stage for what, why we need to expand our maternal health workforce. So Virginia's preterm birth rate is 9.9% with an infant mortality rate of 5.6. And if you break that down by race or ethnicity, you can again see where we see disparities for Black and Brown folks in this space as well. Back in 2019, the governor, Governor Ralph Northam and his administration basically identified that one of the key priorities for his administration was to eliminate the racial disparity in maternal health. And so that is why we're here today to really talk about what that looks like for the maternal health landscape from a doula perspective. Next slide. If we look at social determinants of health, I spoke a little bit about this yesterday, and I said that we can implement strategies to make improvements, but we also have to remember just some of the structural things that are going on in our communities that impact outcomes. And some of the things that we know is that we still have a large percentage of folks who are uninsured, but are of birthing age. There's inadequate prenatal care. What that means is access is not the same everywhere. You heard yesterday about rural access in comparison to urban, but also too that there are gaps in maternity care across the state. Some of the answers to that have been expanding the midwifery workforce, making sure that licensed professionals, licensed midwives, certified nurse midwives can also expand their practice more autonomously. And also in terms of poverty amongst women, as you can see in Virginia, we still need to address these issues as well. And that, this deepens, really our health inequities. And you add systemic racism and that wealth gap, and you really have a true issue, across the United States that we really have to look at. Next slide. In the strategic plan, if you all have looked at that, and I encourage you all to go online and pull it up, you will see that the maternal mortality rate in the state of Virginia in comparison to the United States is lower. However, we still do have a problem when you break it down by Black versus white. You can see 3 times the maternal mortality for Black individuals versus white as well. Next slide. And so really the issue in the strategic plan is that it was elevated that we have maternal health disparities. We have a lot of individuals with chronic health conditions. There's a lack of coordinated care. You're going to hear about this a little bit later and what Virginia's plan is to address that through the Unite Us platform. There are other platforms that are really trying to coordinate care, our EDCC platform that many of our hospitals use. And also the issue is that there's a lack of community informed and led solutions, which lead to the development of projects and plans that don't have the true voice of the community as an informative voice that we need to have in order to move forward. Next slide. So some of the recommendations in the Virginia strategic plan related to doulas were to mandate the Secretary of Health and Human Services to conduct a study and make recommendations regarding a community doula benefit for women covered by Medicaid. And so we started that process, I can't even remember if it's been a year or so probably, where there were 2 groups that were created, one for credentialing and one from a Medicaid perspective, and one for certification certification to really talk about the training and implementation process for doulas for community doulas across the state. There were policy recommendations that included providing a doula benefit for Medicaid reimbursement. And there was an ask to provide access to pregnancy support such as lactation consultants, doulas, and other perinatal birth workers. Next slide. And lastly, what the ask was to expand insurance coverage for doula services to promote access regardless of income or source of insurance. And so we really hit the ground running with the recommendations that were provided after the 10-session listening tour was completed and the evaluations were looked at. And next slide, the end result of that is that we have a doula benefit for the state of Virginia that will be launching probably towards sometime in the spring of next year. We're in the process of working with key stakeholders. DMAS, you heard Cheryl Roberts and her team talk about this yesterday. And so we're really excited, and we wanted to kind of give you that feel for what we feel today is that Virginia is for doulas. Keep in mind, this is not the official icon or slogan for our Virginia certified doulas, but we wanted to cheer this new practitioner type on because it is something that is matching across the United States. This is an effort to expand perinatal workforce on the ground based on using paraprofessionals from the communities in which they serve. Next slide. So I wanted to talk a little bit about the community doula role because that's a little different than working with more of our doulas who are birth or postpartum. There are lost doulas. There are many types of doulas that are used to provide care to birthing people and postpartum folks. And so the role of the community doula, they are they are paraprofessionals who provide skilled and intimate continuity of care through the childbearing year. And this includes support during pregnancy, labor, and birth, and also as well as assistance during the transition to parenthood through the initial postpartum period. Community doulas are generally trusted members of the community that they serve, and they can bridge language and cultural barriers for optimal health and well-being. Community doulas tend to see their clients 4 or more times prenatally or 4 or more times in the postpartum period, and they're often present at the birth as well. It's the one role where the perinatal professional is actually a birth attendant. So they are at that bedside with the client, and they're helping them through their labor and postpartum, their laboring experience. And it is very different from a birth or postpartum doula who has experience in these areas, but may not be familiar with working with marginalized populations who have complex needs. What I would say about the community doula role and the model is that it succeeds because, one, obviously the doulas are from the areas in which they serve, but also two, that trust factor allows for the individual to feel like they have an advocate that really is a non-judgmental voice for the person, the birthing person. And so, really that trusted relationship is continuous, and it helps to bridge the gaps that we sometimes see when clients enter into the hospital system where there are teams of providers that the individual may not be familiar with. And so they can be a very familiar voice in that room with that individual, and they will know them well. They know them better than a person who's obviously never met the client before, but also they work in partnership with a partner or family who may be there also. So next slide. There are wonders of having a community-based doula. We've been doing this for a little while now. Urban Baby is a national model under Health Connect One. We provide training and workforce development for community doulas. And we know that there is a value in having a community-based doula work with your clients. And one of the things we really wanted to talk about today is that care team approach. And not all providers, not all systems see doulas as part of the care team. But what I traditionally see is, but through the use of an interdisciplinary approach, which also includes the doula, the provider has a well-rounded team of individuals that's able to work with the person from the ground as well as through the hospital system and beyond. And that interdisciplinary team is enhanced because they have someone who's non-clinical that's there that knows that individual and can help to provide information, evidence-based information, and help guide conversations that help to connect and ensure that the individual has a positive experience and really is working with their provider to build relationship. And that can happen when that's facilitated by someone that you trust. We know that there are statistical benefits. Comfort measures improve coping and reduce the need for pain. We know that we reduce the gaps in care. When clients don't have advocacy, when they don't have a means of support or care coordination, they're not connected to resources or don't know where to go, the outcomes look very different. And if you were on the call yesterday, you heard me talk a little bit about what that looks like, because I used quotes directly from families who had delivered within the year, and they were willing to share what they felt were challenges. Doulas helped to mitigate those gaps. And we also reduce the burden. I like to use that word because we want to, as community doulas, reduce the burden on our families. And that means that we all shoulder a heavy responsibility for our clients in this space, and also for our clients do the same. So when doulas work with their clients, we're able to ensure that we have a more well-rounded approach, and we can uplift folks and make them feel special and valued, and know that they have a team of people that are working with them. I would also say that doulas help to reduce C-section rates. They improve breastfeeding initiation as well. Doulas that also have extensive training in lactation, they may be CLC, some of them may even be IBCLCs. They can help to triage and make sure that people know where to go to get the help. They provide a holistic approach to care and really trying to understand where is the birthing person in the space that they're in today, how is that going to influence their outcome, and what can we do together to collaboratively understand the view of the birthing person and to put that to action. That improvement in care coordination and connection to resources helps to prioritize and ensure that people aren't lost in kind of the fluff. I know I say it all the time, like sometimes I'll go on the web, and we all do this, web surfing, you're looking for something, you're like, oh my gosh, I have like these 40, recommendations here. I don't even know where to start. And when someone's in crisis or something's going on, that 40-point list can be very, very overwhelming. Doulas tend to have trusted connections in the community, and they'll say, you know what, I know exactly where you can go. This is someone I've worked with before, and I know that you can go here and get the support that you need. And what we know is that people who have support tend to be more engaged in their care, and engaged clients are more apt to attend their prenatal, postpartum, and pediatric visits. And they have better connection to more social needs, such as transportation, social determinants of health, and care coordination through their managed care, because doulas can connect them back to the managed care organization. Lastly, I would say that they provide support during the postpartum period. You heard yesterday an AIM where the AIM bundle is going to be rolled out, and it talked about the importance of having a community-based connection. Community-based doulas provide that connection. They're a second set of eyes in the home. Even though they're not clinical, they can help to address and inform about newborn care, making sure that mom understands about safe sleep and the birthing person has safe sleep space. Again, helping to promote breastfeeding and bonding, skin to skin, being able to identify warning signs. Providers will provide information to a birthing person, and they'll take this whole binder home and packet of information. But sometimes in the moment, there's not we don't remember what that looks like. And so the doula, just by sight, can say, hey, have you called your provider? And again, when health concerns arise, if there's navigation issues in terms of not being able to get to the provider, trying to get to the hospital and things like that, the community-based doula in their home visit can also ensure that that's addressed as well. I'd also like to add that doulas can help inform and promote community-initiated care. And this was a term that was coined by, I was listening to another presentation many weeks ago, and this was brought up. And really, this is about empowering community to make change. In the moment when something has happened, that person is able to share information and connect. And we know that by empowering community, providing evidence-based information, that we can move forward in an approach that is protective versus reactive. Next slide. So everyone wins in this space. Studies show that there are positive outcomes when birthing people have access to trained periprofessional support or perinatal support from those who are trusted members of the community and reflective of the population served. We must remember that doulas are non-medical providers, and they're generally not affiliated with medical practices, hospitals, or licensed professionals, but using collaborative strategies can help influence outcomes when we really work together. I want to mention in that conversation that I hear this a lot, that as clinical providers in the hospital system, we're connecting with people too late. So that means that there's something that's going on that's extreme, that's exaggerated, and we're trying to address that versus trying to be either preventative or to address something before it gets too bad. And using an upstream approach through the use of doulas allows us to address complex needs before they become catastrophic. And for the provider who's overwhelmed in the system, because your role is really to make sure that clinical care, that you've done that medical risk assessment, that you've made sure that they're connected to, their cardiologist or, GI or whomever that may look like, you're putting together that team. It allows for the provider to also have a person on a team that can provide wraparound support services. And they complement one another by encouraging two things. One, the client to ask questions about their care, which increases communication and builds relationship, but also helps the provider to understand when something is changing and not right. Because most of the time, someone in the community, such as a community doula, are going to hear that there are changes before the provider does. And it's not because there's a circumventing of the system. It's just how people do. When you're at a barbecue and someone's saying, "Oh, how are you?" And I was at a barbecue and someone was doing this and they were holding their back, and I'm like, that doesn't look right. And you tend to talk about those things in more casual conversations. It's important to recognize the influence that community doulas can have in others in this space to ensure and protect our birthing folks. So next slide. There are really some COVID-19 realities that we saw in the birthing space over, the last, it's almost been 2 years now, you guys. And really what we saw in response to COVID-19 was a reduction in the number of support people that were allowed in the hospital system, the lack of community-based structure and wraparound services and crisis intervention services were really stretched thin. Many providers, hospital systems, and the like had to pivot to telehealth, including doulas. And they reduced in-person visits, which increased telehealth and decreased being able to see our clients visually. Jenny Joseph yesterday talked a little bit about this, about how her clinic pivoted for her easy access clinic, where they were providing prenatal care to clients who would deliver in the hospital system. And it looked like providing the urinalysis strips, making sure that they had Dopplers, making sure they had blood pressure cuffs, and they were able to achieve a very good outcome because they all work collaboratively. But we still had to pivot. Reduction in visitors also during prenatal visits, so going to the clinic. And the COVID, that reality is that when you have someone that's nearby that can also hear what is going on, they can also help translate things in a way that is more understandable to you, or even just be a support. We know that there's a power dynamic when people enter into the clinical space, And so what happens is that sometimes people shut down. I've seen it myself as a doula, being in a clinical provider's office and the client telling me 15, 20 things that are going on. And then when she got to the provider's office, she shut down and didn't remember all of the things that she needed to talk about. And also, I would say stress systems. We talked about this yesterday. You know, we need really collective rest, right? But we are in an environment where right now this is a pandemic and we're in a health crisis, and our providers and nurses are overwhelmed. Their public health systems are stretched, mental health is stressed, and that reality has created what we see today, which is individuals who are scared, who aren't necessarily sure where to turn. And so we're really trying to build a space for communities so that folks have the support that they need, regardless of if it's a pandemic or outside of that. Next tab. Or next slide. I don't know why I said next tab. COVID-19 impacts. Okay, so I just alluded to that, really talking about the fact that what we're looking at today is that there's increased fear and confusion. So there was a lot of information that was missing during COVID-19 as it related to pregnant folks. Even for Urban Baby, we had to pivot to make sure that we talked a lot about protective measures, masking. We had hand sanitizer. We did a door-to-door campaign to get all of this with the help of get all of these supplies with the help of the health department, the foundations. We all gathered together to help support our pregnant and postpartum folks and their babies. There were challenges about breastfeeding. Do I breastfeed? Do I not? Can I breastfeed when I have COVID? I'm not sure. And doulas really pivoted in that role to understand the evidence. What could we get to share with our clients to help protect the space? Families were being separated from their baby. There was a recommendation that they were 6 feet from the child. If they had COVID, did they wear a mask when they were laboring, or did everyone wear a mask? There were a lot of things that people had to manage. And those with comorbidities and pregnancy-induced chronic acute and chronic conditions were really heavily impacted, because now they had to navigate in a space where they had high-risk providers. They may have had hypertensive or cardiac-related issues, substance abuse and mental health-related issues. And so in that instance, they, again, from the navigation, really felt overwhelmed. And you know, the one person that was there on a continuous basis was that community doula. Next slide. So the response really from the doula community, and I'm going to talk about this on the United States level, right? Because there are doulas all across the United States. They pivoted to virtual support. You had postpartum doulas and others who had to isolate because they were hired to care for the newborn so that the birthing person could recover. And because there was no vaccination that was available, because there was such a high risk to that population, everyone had to pivot to be more safe in this space. They continue to provide education, connection, resources, and really reduce isolation that was experienced by families. That was one of the top things that our families talked about during the height of COVID, which was that they felt very isolated. And we know that parenthood is really not meant to be done alone. They help pregnant people to continue to navigate. We worked with the managed care organizations. We worked with home visiting partners. We continue to see our clients, whether it be virtually or in instances where we had to do something in person, we were there. Whereas there were limited visits where clients could go into the provider's offices, and we all had to make those choices. So having a trained ground forces team is a benefit. Doulas, I found a lot, identified issues that needed to be elevated to providers to help reduce poor outcomes. There were many calls where I received as a nurse from my team saying, hey, I'm hearing something from my client. This doesn't quite seem right. And we worked together to ensure that we could articulate that to the provider, because sometimes a call may sound like, you know what, I'm just not feeling well. And, you know, someone may say, well, you know what, take a break and, 24 hours, you should be okay. However, that sounds different than, listen, I woke up this morning, everything is swollen, my lower legs, all of that. So we help to ensure that folks who needed to contact their providers could communicate that, so that those more emergent issues could be discussed. And if someone needed to go into the hospital, that was what was happening. Or if they needed to go to the provider, or a telehealth visit needed to be set up, that was what was happening. We attended births where we were allowed. Not all hospitals allowed doulas in. There were restrictions. So that meant that people who maybe had gone through birth trauma, people who really needed a solid support system, a trusting person in their space, weren't allowed to do that. And in spaces where that wasn't the case, where maybe a hospital said you can have one person in, but not two, we had to make pivots to where if the partner had COVID, or they were deployed, or there were travel restrictions, doulas were able to respond. And we reduced the load of floor nurses by providing continuous support. It allowed the nurse to focus on important tasks. I can remember being in the hospital, having to get all of this PPE on. I've had all of these clients, especially those are on contact precautions. And it's overwhelming to provide direct support when someone is laboring, when also you have the responsibility of making sure that you're charting, you're checking your baby, you're keeping your provider up to date. And then there's a lot of in-betweens in that too, right? So doulas were able to really help and pivot in that space as well. Next slide. My partner today, who's also part of our task force for the state of Virginia, Kenda Sutton-El, said this yesterday. She said, when there's a crisis, people still need their systems. And this is very correct. We need to make sure that we solidify systems to ensure that there is social support for folks regardless of circumstance. In this instance, it can be very scary to enter into a space where maybe you've heard the negatives about going into a hospital system and you're just not sure. And that social support is taken away from you, and you have to enter into that very system that you're uncomfortable with. And so we always have to remember that. And that was our doula's response. When there's a crisis, people need their systems, and community doulas were right there to ensure that that occurred. Next slide. So I'm going to talk a little bit about just community doulas and workforce development. We have been working on training since 2015. There are other national, regional, and local training programs that support the development of community-based doulas. And as we continue to really work through what that would look like in the state of Virginia, we recognize that a minimum of 60 hours of training in core topics really needed to occur. Next slide. So I want to talk about program application, because some people are very curious about what does that look like when someone works underneath of an organization, and is there a team-based approach to providing care as a community doula? I will say there are practicing doulas that practice independently as well and have been doing that a long time. Urban Baby Beginnings is a community-based system, so everyone that works underneath of our system is supported by us and overseen. I'll also talk a little bit about this project, and this was something that was funded by different funders in Henrico, who really believed that this benefit needed to be available to folks in the Henrico, Virginia area. And so with the assistance of Richmond City Health District and Henrico County Health District, we received a fund between Birth and Color, RBA, and Urban Baby Beginnings to launch a doula program. And so basically these individuals were served, they were Black and African American, and they were able to receive free supportive services by a community doula. Next slide. Some of the outcomes, reminding you all that both Birth and Color and Urban Baby Beginnings do have a training. Each training is different, but it have a minimum of 60 hours of didactic and in-person learning. We focused on confidentiality, safety, communication and partnership, collaborative systems, coordinated care, high-risk navigation, newborn care, breastfeeding, smoking cessation, and safe sleep. Doulas were provided mentorship and oversight by the organizations who contracted them. There was an EHR component and charting requirement, so we did chart to show outcomes, and we partner with hospitals and community-based systems to identify the individuals within that area so that they could receive birth and postpartum support. They received a total of 8 prenatal and postpartum visits and also the birth. And we served over an 8-month period, 134 clients. This was restricted based off of the amount of funding that we could receive. Next slide. And so what we're really talking about today is launching our community doulas out into the community as a new practitioner type. And that's going to really take a lot of effort from many, many people to help us to do that. Our goal is really to provide support and resources and advocacy to birthing people to help reduce birth trauma, increase breastfeeding rates, and connect people to services in a timely manner, but also to surround them with a village and support that we know that can improve birth rates and outcomes. I want to, including infant and maternal mortality. I want to talk a little bit about current challenges. We can go to the next slide. If you look at it from a US perspective, there are states, as Cheryl mentioned, we are the 4th state that will actually officially launch the doula program for Medicaid reimbursement. And what we know, however, is that there have been challenges in other states in the rollout of this particular benefit. And that's why we're really talking about that today with you all, because we're going to ask for all of you to be champions in this work to help us to do this. Because remember, we're all part of the community. We want to see every birthing person have support. So what we know as current challenges is that clients currently aren't necessarily connected in a timely manner to community-based services. You saw that in one of the reports that I showed yesterday, that one of the things that the mom said over and over was that I wish that I was connected to services much sooner. There's really a lack of knowledge about what a community doula does. They are not a birth doula. They don't just go into the hospital system and provide birth support. There are birth doulas. We are not birth doulas. We are community doulas that provide wraparound support. We're reflective of the community, and we follow the client from as early prenatal as that they're connected up until it can be even up to 1 year postpartum. And so we want to make sure that people understand that. And so we need to make sure we dispel myths so that people understand the value and benefit of having a community doula. Doulas are often not considered part of the care team, which limits their ability to support clients. You heard some of the midwives yesterday talk about this. I think Jenny mentioned this in some of her talks as well, that clients fare better when they are part of a care team. And that means that all of us have to work together to define and determine what that looks like. The provider and doula relationship needs to be strengthened. So we want to make sure that we have a way for us to work together and communicate together, because if we're building a new practitioner type, we want to make sure that those who are referring clients for these services are able to address concerns, able to promote and encourage workforce development and information and providing evidence-based resources, but also too, just in that relationship, don't you feel better when you have a strong relationship to the doulas that are providing care for you? We want to make sure that that happens. We've been trying to work with systems so that they understand the capacities of the community doula, but also too, that we have a good working relationship together, because there's going to be times, and there's been many times where I've had to pick up the phone and I've had to call someone because we need help, and we need that back door to get in to do something, and the provider has been more than willing to help us because they want their client to be safe too. Again, we're not clinical providers, but we still need your help. There's variations in training programs and doula roles. Remember I said postpartum, birth, loss. We've got all of these different types of doulas. And also the variation in training program creates a heightened sense of awareness. And so we want to really be sure that when we're promoting doulas in our community doulas for this benefit, that you all realize the amount of training that we're going through. Urban Babies program is actually 120 hours plus all of the in-person learning, all of the mentorship. There's a lot that goes into this space. And this is an ongoing process. Just as a provider or a nurse has ongoing training, we do the same. But we want to make sure that we recognize that there's some challenge in that space, because the initial training that someone has to become a birth or a postpartum doula is very different. And also the lack of coordinated referral systems. Where are the trained community doulas? How do you locate them? How do we connect? So we know that we need to strengthen that process of connection to make sure that we're able to be connected from the hospital level to the doulas in the community. And that's really going to require our effort to think through. I know that DMASH yesterday showed you all a referral form. That's something that we're going to have. So we need to think through this so that we don't create barriers for those who really do need the support. So next slide. I believe on Thursday, this is probably coming up, the response across the US to address maternal health disparities. I believe there's some voting that's going to be happening. There's a federal legislation called the Momnibus. I shared this yesterday, but the title was, it was like a tongue twister, Building Back Better Act, I believe is what it was. And so I want to share this today because it is, again, 12 steps towards strengthening community-based systems to ensure that we can address maternal health disparities. You've heard me talk about the maternal health hubs and the importance of having that safe zone of care. Our work really spans across being able to support that and workforce development. And you can see how this translates into federal policy to ensure that we're able to fund these types of efforts. And so this Momnibus Act is really coming through and talking about making critical investments in social determinants, providing funding for community-based organizations who are working towards improving maternal health outcomes, growing and diversifying the perinatal workforce to ensure that every birthing person in America receives culturally congruent care. There are more points to this, so I wanted to provide you with the source so that you know where to go to find this information. Next slide. In Virginia, we also have our independent response as well. So obviously we talked about it yesterday, the doula Medicaid reimbursement. That is one thing. There's a home visiting study that is out talking about expanding access to paraprofessionals who specialize in maternal child health. And community investment overall. We're really talking about investing into communities to strengthen these systems. And Virginia is really evaluating what that looks like. And again, in partnership, foundations and the like are coming forward to really strengthen what it looks like on the ground to support our families. Another thing that we have done to really increase awareness of what is happening in the doula space is that there is a doula task force. As I mentioned before, there were 2 very large teams that met over a year's time to really talk about what it looked like to implement certification and credentialing credentialing of Medicaid providers. And so that has actually merged now into this task force. And we really want to hear your feedback. And so what I'm providing to you all today is also the town hall link that allows you to see the notes from all of our meetings, if they're when they're approved and posted. When we have virtual sessions, you can actually join as well as a public member. And we want to be sure that you're aware of what is happening in this space. Because as we work to develop and build workforce, we know that right now we're starting small and we're going to get bigger and bigger over time. We really want to have that feedback and strength in numbers to help us to do what's best for Virginia's families. We are excited to announce that as part of that task force, that the chair and co-chair of those committees are Kenda Sutton L and myself. And so we're going to continue to pull this through for the next 2 years to really work on this. And then obviously those plans will, continue to unfold as we go along. Next slide. There are ways that we can work together to change and address community workforce challenges. We want you to share your experiences. You can email the Doula Task Force admin You can attend public hearings for the doula task force. We really want to promote collaboration. We talked about this theme over and over again about working in silos and how it can be deadly when you do that. And we really want to improve communication and partnership between hospital systems, clinical systems, and providers on the ground, along with community-based partners, which also includes community doulas. And we need to discuss ways to expand outside of the hospital. The hospital, yes, is an anchor institution, and you do well in the space of treating folks who are in acute situations. But we also need to work together to build community structures to ensure that community has the same level of strength. We want to promote community-led solutions to perinatal issues, focusing on workforce development. We have a plan in place for that, and programming in communities that help to expand the doula workforce. It's nothing to have access to something and then not be able to get it because we haven't worked together to build that bridge and relationship to ensure that our clients are well served. We would love to see that you make space in your practice for discussions on ways to partner with community-based organizations who are trusted members. And yes, it's going to take time. Time I know that all of us may not have, but if we keep at the core and the center that our community is so important and our clients are so important, we'll make that time in that space because we do it because it's important. And we want to encourage community-initiated care by empowering families, sharing information, sharing evidence-based resources and information at during the prenatal period. When we empower families and we encourage families to be a part of the birthing space, when we share that information, we change generations because they take that and they're able to share it with their children and their children. That's why we use the birth plan, birth wishes document, birth preferences. It's called many different things. And we really use that because we want to change the trajectory of what we know today and what we're going to be sharing with our children in the future. And we would like to also work together to support mentoring programs that build paraprofessional perinatal skills through experiential learning and didactic experiences. There are programs that have opened their floor similarly to how nurses are on the floor and they train. Workforce development can look like something like that, where doulas, are part of training in some capacity. It can look like someone volunteering an hour or 2 hours to talk to doulas about something. The other day, it came up about trauma-informed care, sexual domestic violence. These are things that, substance abuse, these are things that doulas have interest in and need to know about so they can better help to support their clients as well. Next slide. And so really my final words today are that we're here to make sure that and ensure that Virginia's families and their babies really have the best start to life. And that's going to take all of us to create a workforce that is community-based and focused with the part of the community at the center. And we really encourage you all today to take back this information, to share this exciting benefit, to know that we're working hard to build workforce and that we're going to need your help and we need champions. Just like yesterday, we talked about emailing in because we need champions in this work. We want to have champions in this doula space because we want to know that our providers, that our nurses, that, our care partners are really committed to ensuring that families have the best level of care. And then that also includes that doula as that care partner. As we know more, we'll continue to share. What we look forward to is the coming months where the task force continues to strengthen and continues to work towards the implementation of this benefit. Understand that there are a lot of key partners at the table in that space and a lot of moving parts. But what we ultimately want to see is an improvement in outcomes, an improvement in these surveys, an improvement in, just how we feel overall about empowering our families to make the best choices for themselves and their children. Next slide. If you would like to contact either of us, I have provided our information here, office phone numbers, email addresses, websites, so you can find out a little bit more about our work. We'd love for you to reach out so that you can find out more about what's going on. If it's specific, obviously, to the Doula Task Force, we will forward information over to Virginia Department of Health. We have a contact there that's helping to manage that piece of that. But also too, again, we want to encourage you all to reach out to understand about this doula, how doulas can impact your organization, how they can help in the long run, and what that looks like when you're working with community-based organizations such as ours. So I'd like to thank each one of you. Next slide. And just remember what we're saying. Virginia is for doulas. We're very excited. Thank you for your support. And we look forward to these coming years to see what this will look like for Virginia families. So I'll open it up to questions if you all have any. And I appreciate you all's time.
Excellent. Thank you very much, Stephanie, for that wonderful presentation. We do have a question in the Q&A part, and it says, does the state intend, and I know it's hard to speak for the state, but does the state intend to mandate vaccinations, COVID, flu, up-to-date MMR, Tdap, etc., for community doula licensures?
That question needs to be diverted to probably DMAS and others, or BDH. I'm not sure. I'm not able to answer that question. I'm sorry.
Okay. And then Stephanie, a couple comments, great presentation. So excited to see the progress over the last few years. Stephanie, your presentation resonated so well with me. I had the opportunity to recently interview a midwife from Rwanda who alluded their success in turning around their high maternal and infant mortality rates by having a strong community health worker system with effective communication from grassroots level to the RN, to the midwife, to the physician and the tertiary system, and it works. Wishing Virginia the very best as this program rolls out. Thank you, Nola. Another question is, what challenges or barriers do you see most difficult for Virginia?
I think a couple of things. I mean, yesterday we talked about rural, very briefly about what the access points are in the rural spaces. I also think that, and I'm going to use history from other states and their rollouts for doulas. I've talked to many doula organizations, many states about this work, and really there was a barrier in terms of getting providers to sign off on the referral for the individual to be able to see their client. I think that, again, communication, making sure that people understand what the doula benefit is something we have to work on. I think that it's going to be a challenge because we're trying to reach so many people. So if you think about it from, let's just use COVID terms. This is a huge, was a huge pandemic. We're trying to reach a lot of information to tell them, where do you go to get tested? Where do you go to get information? Where do you go to get the vaccination? When you're rolling out something as large as this, and it's a new provider type, it's something that we have to remember a lot of people don't know about. They don't know the benefits of it. And we really don't have, we need to strengthen that communication plan. So I think that that's also a barrier. And lastly, I would like to say, we really look at cultural influence, right? In terms of what it looks like to support someone who's Latinx, who speaks Dari and all of these other types of things. And so what does that cultural influence look like when we may have a lack of providers in those specific spaces? So I would add that as well. I'm sure there are other things in that space, but those are the top things that come to mind today.
Thank you, Stephanie. Another question, such a terrific program. Any data on outcomes we can share in the discussion as we converse with policymakers?
Can you repeat that question one more time?
Sure. Any data on outcomes we can share in the discussion as we converse with policymakers?
And so in this discussion, really, we looked at statistics from other states and also looked at evidence related to studies that were available online, because obviously Virginia has not rolled out this benefit. So from a statistical standpoint, they can't use their own data to be able to inform, because we haven't rolled out doulas on a mass scale. But I would say that there is data that is available in other states that would be related to this, that would help to continue to inform and to push for policy change. Questions are rolling in.
So regarding working in the hospital setting, there seems to be a negative or uncomfortable stance between doulas and the clinical team. Have you experienced this bias in the hospital setting?
Yes, for sure. I mean, the hardest thing I think as a clinical provider and also as a community doula that I see is that there is a power dynamic that presents itself when a person enters into an institution. So what it means is that I have sat in someone's home and they have told me truly how they feel and what they want and desire. And, you know, they've got this birth plan and they've got all of these things. And then we enter into the hospital where there are policies and procedures, and some of those things aren't meshing very well. And so I have experienced that. And I think that how we mitigate that, again, is by opening our doors and communicating with one another so we can talk about how do we, at the end of the day, have the outcome that we're all really looking for, because we're all looking for the same thing, but we also want to make sure people are well respected in that space. And so I look at negative or uncomfortable stance as opportunity. And I think that we have an opportunity to address that. And we want to see strength in this process of collaboration. And that means we have to be willing to sit at the table, all of us, to talk together about what that looks like so we can make it better.
And just a caveat or follow up on that, Stephanie, I think with the rollout of the 4th trimester and being very intentional with including doulas and community workers in that throughout all 6 phases, I think that is another, as you mentioned, opportunity for us to have some of these conversations and start to unpack some of the perceived negative or uncomfortable stance and work together to identify, what concerns are and how we can, mitigate or provide an opportunity to all learn. One more question. What effort is being made to educate women in the community on the importance of doulas for maternal health before the rollout?
So we actually have a communications team with the task force, which is really talking about this. You see sporadic efforts like Virginia Department of Health did a campaign, a billboard campaign to educate people on the benefits of doulas. We've done sporadic rollouts in regional areas to talk about doulas and the importance of that. You'll hear in some of the sessions that we've done, which are more, again, regional, where we talk about the importance as well. But as far as a statewide awareness campaign, we're really talking about what that looks like on that task force level. So I would say that there's more to come. This is also a start of that, because when we're talking about educating folks about the benefit of having social support and doulas, all of us have the responsibility in that space. So my hope today is that we'll be able to go back to our clients to talk about that this is happening. I see the managed care organizations also opening up their baby showers to talk about doulas. There's a lot that's going on in the space. We hope that that's going to be very well coordinated so that before we actually roll out the benefit, we do have an awareness campaign that is very solid, that really addresses providers, stakeholders, folks who are actually going to receive that support as well. So again, we want to encourage feedback. If there are suggestions, many of you all are providers, we want to hear from you about what would make it better for you. You know your clients, and we want you to talk to us about what this could look like, because we want to reach as many people as possible. And also, just at the end of the day, I want to say the same thing, is that perception, whether negative or positive, is one thing and can be combated by what? Communication, collaboration, partnership, and really us bringing all of this to the table to talk it through. So we're really excited to see this work come to fruition. Really want to see, you all put your efforts as well towards this, because this is about all of us, and building the support is going to take all of us to do that. Did I see one more question popping up or no?
Yes, one more question. Lauren Barnes also mentioned she's with the Motherhood Collective here. She's actually the lead for the statewide communication plan on the Virginia Doula Task Force. So she's provided her email address in the chat for anybody that would like to provide her any ideas related to the communication aspect. And then one other question, has there been any discussion of compensation rates for community doulas so that it is in line with, at minimum, living wage and at maximum in keeping with the value and healthcare savings provided?
There have been conversations about that. Those conversations were hosted by DMAS and others in those larger teams that I talked about. And the summaries and all of those things were completed, and the analysis was informative, which helped Virginia to determine and suggest what those rates would be. I think that those conversations can probably be passed along as well, or that question can be passed along to someone else.
All right, excellent. Oh, sorry, one more question. We're gonna wrap up with this question, and if you have any more that come in, we will work after the summit on getting a response to you. But so the final question is, how do you envision doulas and nurse care managers that are providing home visitation work together?
That's a good question. So home visiting and doulas have been, because there are some similarities, but obviously they can work together in partnership to ensure that individuals support one another appropriately. What I will say, without necessarily giving a full, answer to what that looks like, is that in the home visiting realm, there have been conversations about what we can do together collaboratively to ensure that clients have the best level of care. And that also requires that we evaluate the need, because it may be that there's more of a need for social support prior to home visiting, or it may mean that there's wraparound services that require for both. I don't have the answers for either of those, but what I do envision is a client who's well supported, whether or not they're in home visiting, whether or not they're with a doula, or there's a collaboration that exists between the two.
Thank you very much, Stephanie, for being here today.
You're welcome.
And again, an excellent presentation. So without further ado, keeping with the agenda, we will move on to Jason Jude, who is the Community Engagement Manager for Unite Us, and Jackie Cornell, who's the Senior Director in Regulatory and Government Affairs. Are you able to share your screen, either Jason or Jackie? Oh,
I'm about to share right now.
Okay,
Good morning,
perfect.
everybody.
Good morning.
Can everyone see my screen?
We can.
Excellent. Thank you so much, Shannon, for inviting us. I am so excited to speak with you all today. As Shannon mentioned, my name is Jason Jude. I am the Community Engagement Manager for Unite Us, serving the Washington, D.C., Northern Virginia, and suburban Maryland area. And I'm going to let my colleague Jackie introduce herself now.
Hi, good morning. I'm excited to be with you all as well. My name is Jackie Cornell. I'm the Senior Director here at Unite Us for Regulatory and Government Affairs. I cover about half the country, but that includes Virginia. And I'm really excited to be with you all this morning to discuss this. I was the Deputy Commissioner of Health in New Jersey, where maternal and infant health was one of my marquee key priorities. So I have a long history in doing this work in different states. So excited to be with you this morning. Thanks so much.
So thank you again, Jackie. So without further ado, we're here to discuss a new model of care that is really being driven by the community. And that leads us to what we used to think of healthcare. Now, when people think of health, they think of healthcare, they think of the clinical setting. Unite Us was actually founded on the idea that while those are major parts of it, it's not the only part. A lot of what factors into a person's health derives directly from the community in which they are living. And so we want to make sure that when we're talking about the community, that we have people with access to the different resources in the community. And we're really thrilled to be able to talk to you a little bit about how Unite Us does that. So for those of you who are not as familiar with Unite Us, we are a technology company and an electronic referral platform. We were founded in 2013 by our founders, Dan Brillman and Taylor Justice, and we're actually a veteran-founded organization. They came out of the service and walked into a fragmented landscape. So trying to navigate different silos, whether it be government benefits, whether it be community-based organizations requirements, was found very difficult for them to actually get the help that they needed. And so after looking around for a solution, they realized that the best thing they could do is go and build one. And so what they built was the Unite Us platform. And what Unite Us, the company, does is we help build coordinated care networks across the entire nation. We're in 44 states right now nationwide, and we are proud to be partnering with some of the amazing institutions you see next to you, right here on this screen. And we are of the idea that when you can build out the community resources, people can get access to help sooner. Really what we're trying to do is go from the old model, which is the before, to the after. Originally, when people are doing this, they realize that, number one, they start losing visibility into their clients once they leave. It's very hard to keep track of folks once they leave your four walls. Also, folks have to keep giving the same stories over and over again. And a lot of times, these are pretty traumatic stories. They also don't have the data that can actually show the impact that's being made by all of the work that they're doing in the community. And we're trying to build things and bring it over to the after. And that is where organizations and providers across the spectrum can actually send secure electronic referrals. They're also able to track the entire client journey. They're also able to collaborate and coordinate services to help the people that they're trying to serve. And so this is what we're trying to build, and this is what we're trying to bring across all sectors so that folks can get access to the resources they need to improve their health. Now, a little bit about what we're doing in the great Commonwealth of Virginia. In 2020, at the end of last year, we were picked by the governor's office to support this Commonwealth infrastructure. And so we started with 3 legacy networks at the beginning of the year in the North, the Northwest, and also in the eastern part of the state. And we have now built out to be covering almost 80% of the population, and we will be Commonwealth-wide by the end of this year. And to add a little bit to that, we are making sure that there's local engagement teams at every single region of the state. So we have engagement managers in the Northwest. We have engagement managers covering the Southwest. We are making sure that there are people there who know the local feelings, and they'll be able to support our providers with their knowledge. And we're thrilled to be working with the institutions there, our community partners, who are bringing resources and their knowledge to this entire effort. Folks like Kaiser Permanente, the Virginia Department of Health, Optum Health, Virginia Mental Health Access Program, Ballot Health, the Virginia Department of Social Services, Partnering for Healthy Virginia, Virginia Hospital and Healthcare Association, and Ballot Health. So all this comes together to bring one amazing initiative. And the thing I want you to take away from this is we're here to partner with you. And one of the things we want to make sure that you know is that this is free of charge for our community-based organizations and the folks driving impact directly in their communities. And it's free of charge because we don't want you to think about the budgetary constraints when you're looking to improve the folks that you're serving. So we want to make sure that you have the tools you need to provide this impact. We want to make sure that you save time. We noticed that when folks are using the Unite Us platform, they're spending less time following up. They get that insight into the client's journey, and so they don't have to bridge the gap themselves by calling or emailing or texting just to see what happened with someone after they left their services. We want to make sure that you have the ability to enhance the care. So even if you have the folks that you're normally working with, the organizations that always seem to pick up the call, we want to make sure that you actually have more resources. One of the things we always learn is that when the folks join the Unite Virginia or the Unite Us network, they learn about new people, they learn about new organizations, they learn about new resources. And that leads us to, we want to make sure that you have the data and the insights to start filling in the gaps in your communities. One of the things we're able to show is overall how people are responding to help. Where are the gaps appearing? What can we do to fill them? It's overall, it's going to be your story. We want you to be able to tell it the way that makes the most sense for you. So can you measure impact through data? We want you to be able to do that by seeing how different populations are responding to help. We want to make sure that when you go to talk about what your community needs, you have something actionable to tell them. We want to make sure that not only can you see what your organization is doing, we want to be able you to see what your network is doing, the people and the organizations around you. All of this is what's going to help drive the community change and make sure that community is able to support the folks who need it the most. And with that, I'm going to turn it over to my colleague, Jackie, to give us some maternal health and more relevant examples here of what Unitas is doing in this field.
Awesome. Thanks so much, Jason. So this is a typical way that we would walk a expectant parent through the journey here with Unitas. You'll see here the example of Sarah as an expecting mother who arrives at an FQHC. She is screened at that visit, and it's been determined that she has several issues: transportation, food insecurity, and housing instability. Not surprisingly, these are typically the top 3 issues across the country, the order of which is sometimes changes, but these are the biggest issues that we're seeing, not just for expectant parents, but sort of universally. And I think that's partly because of what we are all collectively still dealing with, economic insecurity because of the pandemic, right? And the sort of the residual effects of what's happened there. The referral is used, Sue uses Unitas to gain digital consent and electronically transfer Sarah to multiple community partners. What's great is that she can seamlessly communicate with other providers in real time and securely share Sarah's information. Years ago, I worked at a community-based health center, and I'm sure many of you are still doing this now. It was one person who had the relationship at the crisis housing facility. There was another person on staff who had a relationship with the food bank. We were sharing information via email, via fax, via phone call. It was incredibly fragmented. Using the Unitas model, everything is seamlessly put together. And not only can Sue screen what's going on in Sarah's life and how those visits and subsequent support is being happened, but she can touch base with the organizations as well and say, did Sarah come in? Have you heard from her? So that the next time Sarah comes in for her next checkup, Sue can have a sense of what has happened in the absence of, in the space of that time. Sue is receiving real-time updates and is able to look at Sarah's total health journey. One of the things that we really understand is that the junction between mothers, expectant parents, and children extends far past just the pregnancy. And so I think the next slide, Jason, if you'll pop us there, kind of talks about that. We are very attuned to the fact that the priorities and the objectives of our partners are beyond just the prenatal period and the birth period. But what is going on in that 4th trimester? What is happening in the subsequent 2 and 3 years after birth? How are we looking at the variety of different things that, moms, expectant parents, and their children need? So for us, this is not just what do we do in that moment? How do we help Sarah, at that first visit to the FQHC, but how do we help Sarah's family? And this ability to get in and work collaboratively with partners on the ground. So connecting to doulas, home visiting, social and clinical care, realizing that in almost every state we operate in, the silos that exist sometimes between WIC, SNAP, Medicaid, pre-K, how can we help to make that easier for women like Sarah, families like Sarah's, who, if you're eligible for one of those programs, you're probably eligible for all of those programs. And how do we help to make that as easy as possible for the families? Working to provide insights to health plans and to government, right? Being able to say, this is the use, this is the issues that are coming up, how to help drive, from where I sit, budgetary and policy changes to address food insecurity, housing insecurity, transportation issues, when we're able to see these trends over time. For me, is really how you get upstream, right? Of course, we're in it to help immediate families and help communities directly, but how do we go upstream of the problem and start to unpack and address some of the systemic issues that are leading to, housing insecurity, food insecurity, and the like. We work very hard across the country to leverage evidence-based and evidence-informed interventions and take best practices that we're learning in other places. And I'll show you an example one of our programs in Florida in a second, but bring them and sort of act as a information, repository and share of best practices for organizations. So you'll see an example in a second. Collaboration with public health departments and realizing that they, in many instances post-pandemic, or we're still actively in the pandemic, how stressed they are, how taxed they are, how can we be supportive and engage with them? And then also sharing data as is appropriate to make sure that we're being able to get at these real, county level, community level inequities and address them in more meaningful ways. I'll take the next slide. So we've already seen that there are some big benchmarks that we really need to address. And some of these are repeated from the last slide, but it bears repeating, I think, because they are so important. Access to high quality clinical care. Realizing that one of the things that Jason and his team is doing on the ground is making sure that the providers and the community partners that we're sending referrals to have the capacity, right? The worst thing you want to do is send someone down a path to receive help and they can't, the receiving organization is at capacity and can't help them. We work to make sure that referrals are being closed. And if they're not being closed, what's the holdup, right? Is there an issue? Is an organization at capacity? We work very hard to address the social determinants of health. And so trying to look at what are the things beyond the reason that the woman or the family is in the clinical setting in the first place. And I highlighted a few of those reasons. Giving clinicians the tools they need to quickly refer high-risk patients to non-clinical resources. We also have within our networks a hub where we can work to bring in sort of high-risk folks with complex needs and be triaging them more meaningfully and supporting them more meaningfully. So a great example is, let's say in Sarah's instance, she went to the food pantry and got some additional, food, whether it's a basket or vouchers or what have you. And at the food pantry, she presented as having some either substance or behavioral or mental health needs. Now, the person working at the food pantry might not know exactly how to triage that. They can call upon the network hub specialists to say, here's this person, she's already in our network. I can see that she's struggling with something, but I don't really know how and what to direct her to. We have experts who can come in and really help to guide Sarah into better supports. So it's not incumbent upon every clinical person to know the laundry list of social service agencies. And it's not incumbent on the social service agencies to have to diagnose and do clinical interventions either. That's the beauty of this network working all together pretty seamlessly. Again, we've talked about how do we share evidence-based informed interventions across organizations that we're working with and sharing best practices, and really trying to look at what are ways that we can continue to bring up novel interventions. So are there pilots that are happening in Virginia that we want to share with other partners and vice versa? So this is probably a good time to jump to the slide on Florida. There we go. So in Sarasota, this is one of our first 1,000 days projects that we have going on. So first 1,000 days, again, is looking at that first 3 years of a baby's life and really trying to do a couple key things. First and foremost is parent empowerment. So creating a space, a portal for parents where they can learn about different things, sign up for developmental activity text messages, and also reach out to use Unite Us assistance request form. So if, let's say, they are going through the activities that are there and they feel like their baby is not meeting those benchmarks, there's a mechanism to they're not just stranded saying, oh my goodness, I tried this exercise, something must be wrong with my baby. I have an 8-year-old, but I still remember those early months where Dr. Google and my mother and my mother-in-law were the resources that I had. And when something you think is wrong with your baby, you panic, right? You want to find the fastest resolution possible. So I think it's really important that the tools are not just educational and one directional, but that the parent can then respond back and say, hey, I'm concerned that my baby isn't meeting this benchmark, or I have additional questions. Who can help me with that? Which I feel like is incredibly important, because just giving new moms one more thing that they're supposed to, do with their baby. And again, I'm kind of going back a few years, but it felt like everything was a test of like, how well is my baby doing? And am I messing this up? For first-time parents, especially young mothers, it can be an incredibly overwhelming period. And so being able to respond back into the system when there is an issue, I think is really empowering. We obviously, we've talked a lot about care coordination already. Here in Sarasota, this example that we're showcasing, 65 organizations and over 110 unique programs have been joined together to create this network. And so it's everything from local government to pediatricians, OBGYNs, et cetera. We work really intentionally in all of our states and all of our populations to try to do advisory committees. So at every state, we have network advisory committees. And then in a lot of examples where we're doing either specific population, maternal, substance abuse, et cetera, we have patient advisory committees in that subset population to make sure that what we're doing works, right? I am a huge proponent of, we are a technology company that brings local folks into the network and to support the network, but we don't know everything. And it's really important to me that we have that opportunity to hear from people that we're serving and to do so meaningfully. And it's not just something we sort of throw up on our website. It's something that we take very seriously, because that makes the network stronger and helps to serve more people more meaningfully. We work, again, really hard to make sure that the partner organizations are being heard and that we're leveraging great opportunities out of that. So we have a client navigation work group that helps us to make sure that the tool itself, the actual tool that the partners are using, is working. So it's not just a feedback loop for the patients and the consumers of the network, but actually all of you all on the back end want to make sure that it's working for you too. It's really important. And then really driving into a plan of safe care. So having those conversations, working with a countywide task force for that issue. And this is part of a federal mandate as well, but really driving at how do we engage specifically for women with a history of substance use, to drive at this plan of safe care for those families, and realizing that this is an opportunity where we're being able to leverage both federal, state, and local government support to do that work. Next slide. I think that's back to you, Jason.
Yeah, and so just to kind of give you a quick little overview, Unite Us wants to make sure that you're using this confidently. We adhere to the highest federal standards for compliance and security. We recently were given our high trust certification, which, as you know, is a very high level that we had to meet in order to get that. We're hosted on encrypted servers, and so data and communications are fully protected from end to end. We also have different features such as sensitive organizations and sensitive service types. So even within the actual Unite Us platform itself, not only can we make sure that only organizations in the direct line, specifically you're talking about things like domestic violence, et cetera, are able to see the particular information for those cases, and that is not accessible to outside organizations. So we are also HIPAA compliant as well, and 4 CFR, and several other acronyms as well. We do this just to make sure that not only can you use this securely, that the clients you work with can also use this. And I do see that there is a question here. How does Unite Us address undocumented clients and the uninsured and underinsured? And so there are actually, I can tell you a couple of different ways. Number one, we only take 3 touch points of information. So only first name, last name, and date of birth. That allows us to work with several different populations. We also have our materials and our consent in several different languages as well. So including Spanish, Vietnamese, Arabic. I've seen a lot of different ways that this can be translated. The Unite Us platform itself also closely works with organizations serving the immigrant population and underinsured populations as well. And we use our data to help fill in those particular gaps. So even if there are has some resources on there right now. We are working to make sure that plenty of them get onboarded when we see those gaps appear. And so there's also ways, and I can show you this in the platform, to filter for specific populations too. And this is actually probably the best time to move on to the actual demonstration. I have a very brief one fired up, and I'm going to stop sharing right now while I get that demo environment up for you.
And Jason, while you do that, I see a few other questions here that have kind of popped up. If you don't mind me trying to tackle them while you grab the demo, does that work?
Sounds great.
Great. The question here is how in rural areas they have poor internet services, which essentially becomes a barrier for telehealth as well. If we consider this an SDOH, how do you address this and how could this be resolved? I think that's an incredibly important point. There have been countless articles talking about the benefits of telehealth, and only a small fraction of them highlight the fact that telehealth only works for a very specific universe of families and people if they have reliable internet access. And so I think one of the things we're doing on the global level is having these conversations with CMS and the federal government about how to see broadband access and internet access as part of a direct need in receiving care. At the state level, I can't speak directly. I don't recall if we've addressed this at the state level, but I know that it has been something that we've been raising federally as a mechanism to flag for CMS to say, how do we use CMS dollars? Is there a potential solution to address internet connectivity and just unreliable internet service? I think that this might also be something where we would partner with Department of Education, because this has been one of their big issues in light of the pandemic and how so many children were brought into virtual school and yet didn't have the internet to support it. So I don't have a clear answer, Nola, right this second, but it is something we're very mindful of and have definitely been talking about at the federal level. And I can add it to my list of things to discuss within Virginia as well.
And I think there's one more question before we jump into the demo, and it's from Anonymous. Are there systems closed within states? Are there firewalls to prevent mass transfer of private information in cases of system breach? That's a fantastic question. And so one of the things we do, we're set up primarily as different networks across the entire country. And so within each networks, we are designed on the back end for security and making sure that there's limited access to personal and private information. We're also independently audited specifically for things like data breaches and other like system failures to make sure that we have multiple redundancies in place to prevent a mass transfer of private and protected information. We've gone through a lot of different consultants and research to make sure that not only can organizations use this confidently, but even the particular users can feel like their information, once it's on Unite Us, it will be protected. All right. So right now, I'm going to jump into the actual really brief demo of the platform itself. My colleague Jackie will be on the chat if you're throwing some questions in while I'm going through this, and we'd be happy to also have some Q&A right afterwards. So right now, what you're looking at is the Unite Virginia website. The Unite Us platform is a web-based platform. So that means that you can actually use Unite Us platform on any device that you prefer. So if you like using your tablet, if you like using your cell phone, you can use Unite Us platform and be connected to your clients anywhere that there's an internet or data connection. The way you would sign in is you go to Network Partners from the site, and then you just click Login, and you will use your email and your password that you would set up yourself. Something I'll highlight here as a practical feature is you're always connected to someone who can support you. This is what we call internally our magic chat bubble. If we go here, you're able to see that there are user experience specialists who will be directly responding to any issues you might have. All you have to do is click send us a message, and there are people working around the clock to make sure that you feel supported, whether you need something as simple as your password reset. There is someone on the United staff who is making sure that your questions are being answered. But once you do sign in, it'll take you to right here. Right now, you should be looking at our blue dashboard. This is our fictitious environment. Again, we populate with data just to show you how it works, but you'll see a few different things right off the bat. Number one, I'm signed in today as Sylvester Copeland from Be Well Health Clinic Home. I'm able to see immediately the referrals that have come in to my organization and the status of the referrals that I made outside of my organization. So I can see open cases, I can see those closed cases. And that goes right back to what I mentioned before, and that's the outcomes data. So we're knowing right off the bat what's going on with different individuals who are coming into our orbit. The next thing we do is we want to make sure you're able to see the different status and the timeline. And we're able to go right here to the timeline feature, and you can see everything that's been going on in your organization within the past couple of days. So a lot of folks have different systems in place, whether it be binders, spreadsheets, maybe different ways that they keep track of what's going on. We like to make sure that you get all that information as fast as possible and in real time. So if you ever had a question as to what's going on, all you got to do is go scroll through the timeline feature and you can check that out. Now, in terms of being able to sort of manage your clients in different cases here, we're able to help you categorize all that by going to the clients tab. So right off the bat, you're able to see not only all the clients working with the organization, you can also see information about their particular client journey. For example, we can go here and we can see the care team. So these are all the individuals that have worked with Mr. Alston. We can see his open cases. We can also see that client's particular timeline and keep track of what's happening with this particular individual. He doesn't have to go through a history that maybe he doesn't remember every aspect of it. We want to make sure that you have the ability to also work with this folk and see their history. And that we're also able to update their profile. So as information changes, we're able to update that in real time and keep track of information such as household members. Oftentimes, many of you work with families. We want to be able to track that information too. And last thing I'm going to show you here is we're able to go in and you as an organization can control your presence on the platform. For example, here you can control what programs you have receiving referrals. You can edit that program's information and you can update that whenever you need, including putting in your eligibility requirements. We go here to edit. Not only can you do all of that, but if you're ever at a point where maybe you're not necessarily in a good place for taking referrals, a particular program, all you have to do is go here and turn off that ability to receive program platform referrals. This way you can control your capacity and your own workflows. Now that you've kind of seen some of the cool stuff that's able to help you really control your presence on the platform, I'm going to show you exactly how we do the referrals sending and receiving. So to send a referral, all you have to do is go here to this plus sign, you click on that, and you click new referral. And this goes back to what I mentioned before. All we need are the first name, the last name, and the date of birth to begin working with a new client. So if we put in information here, let's say, so we're going to begin to build out this new profile, and we can put in information such as their first name, last name, date of birth. That's required. You'll notice by that little red star there. We can choose to put in the social security number, but we don't have to. But we can also put in information that pertains to their demographics. So we can put in this information such as a gender. These are our options here. Marital status. Race and ethnicity. And we can also put in contact information. So if we want to see how we can stay in touch with Fulfill, all we have to do is put in this email. And now we can actually message them right from the platform and set them up for notifications too, so they're kept aware of their own journey. Same thing with phone numbers. Now we can call and text right from the platform. And we can also set them up for notifications as well. So if you're ever in a situation where you're like, we need to remind a client that they have an appointment, you can do all of that right from this platform. And we can also put in information such as their address, but we don't have to. We understand that in a lot of cases, people are housing insecure. So we would just put in nothing here and we'll be able to search the area around our particular location. And we can save this client. And now we're going to come to the heart of the Unitas platform, and that is making sure we're connecting people to help. So I'm going to go and search based off of our service types. We have over 130 different service types to connect people to services. Anything in black is our parent service type, and anything in blue is our subtype. So we're going to go and look for something that we've actually seen across our, our networks that's actually become necessary, and that is career skills development. We've seen from the data that a lot of people are looking to upgrade their skills and change careers. Now, we can go here and we can see all the different organizations that serve that particular need within a radius. Not only can you see all the different organizations that serve that need, you can actually go and filter for particular help. So let's say you want to serve a population like adolescents. You can also serve caregivers.
Jason, there's actually a question right now that is perfect for this. It asked about specific languages that the individual wants to be contacted in. So you're right at the screen where you would do that.
Yeah, exactly. That's a great question. So you go here and you can see we have several different languages that we can actually work in. We understand, especially here in the Commonwealth and in the Mid-Atlantic, we are a melting pot of a lot of different cultures. And so you're able to actually get services in several different languages. A couple of weeks ago, we actually worked with an organization that specialized in Southeast Asian languages. So Hindi and Tamil and everything like that. We're making sure that this is reflective of the communities that we serve, and we want to make sure that folks, even if they speak a different language, can get that help.
And a quick question that just came in, Cindy asked, how are community partners identified and connected into the system? And that's essentially what Jason and his team do all day long, is to work with and identify both who are great partners to be brought in, and also where are there gaps and saturation, right? Unfortunately, for certain issues like housing or substance abuse, sometimes there's the need outpaces, the demand outpaces what we have in the system. And so we work very collaboratively, talking with folks like you all to figure out who should and wants to be a part of the system. Jason, I'm not sure if there's more you want to say about that.
No, you pretty much hit the nail on your head. The only thing I would add is that we also love to work with your different networks as well. We want to make sure that the organizations you're working with are also on the platform, and we work with you to make sure that this also translates over into the network. Because oftentimes, it's easier to begin when you're already familiar with folks. And so we work directly with you to make sure that the organizations you are currently engaging with are also on the platform as well.
And one more question while you're right in this space, it asked if you could click on immigration.
Yeah.
I guess this population is specialized in serving. Yeah.
Yeah, of course. So you can click on this, but again, this is our fictitious environment. So we only have this one organization in our fictitious environment that serves, did I click on that? Yeah, immigrants and refugees. We do have several more, especially in the actual live environment.
We're caught up on questions. Go ahead. Just
All right.
felt like we were in a great spot to answer some of them right there. Thank you.
Of course, when we're on the screen, we might as well. So we can also look at quickly at the accessibility features, because we understand that different individuals have different needs. So things like ADA accessible features, blind accommodation, deaf and hard of hearing accommodations, as well as interpreter and translation services, going back to what we were just speaking about. And you can also change the different distances. So let's say your client doesn't have a car. A 50-mile radius is pretty big. You can actually set it to 1 mile, so they can actually walk to different services if they need to. And what I'm going to show you before we move on is actually what it looks like when you click on an organization in the platform. So when you click on an organization, you're able to see their profile. You can see their program details, things like hours of operation, how to contact them, and eligibility requirements. So here we can see only individuals who, in this case, live in Arlington can refer to this particular place. So this way, organizations can control how they interact with the platform, and people get to go to the place where they're in the best fit. So I'm going to pop out now. We're going to go with this organization, and I'm going to show you another feature of our platform, which is the referral description. In a lot of cases, individuals coming to you probably have traumatic backstories. And one of the things we like to do is make sure that information gets to the right place and only at the right place. So here we want to make sure in this referral description to highlight things such as urgency, any particular special situations. But in the interest of time, I'm going to give a pretty abbreviated one. And we're also now going to show you the documents feature. So in a lot of cases, things such as, maybe in this case, we're doing career skills development, things like a resume or a cover letter are pretty useful to attach to a person's referral. This also works with identification and other files or relevant documents that really need to travel with an individual. We click next, and then we're able to actually do basic assessment questions. You don't have to fill this in, but it gives a really great picture of the individual going to the other provider. And now we can get a snapshot of the individual referral before it goes out to make sure it's correct. And now we can submit. So as we mentioned before, we are a HIPAA compliant platform, and so that requires getting informed consent. We have several different ways of actually getting this consent, and we can do it by attestation. We can actually get it by text message. So that phone number we took down before, we're able to text it to the individual. We can get it by email, actually on screen. So a lot of you who are working in person with different people can actually have the person sign that consent right there on their tablet, right there on your anything. We can also upload a signed paper form. So if someone's not comfortable with technology, all you got to do is have them sign the form, and you could actually scan it right into the system. Same thing with audio files. So if someone gives their verbal consent right next to you, you can put it right into the platform. And I'm going to show you what this looks like right now. We go here. This is our really narrowly tailored consent form. It's simply used for information sharing on the Unitas platform. So if you have another consent that you use for your daily activities, we'd be happy to speak with you on that particular workflow that makes the most sense for your organization. But for now, we're able to go and get this consent just to share information. And we're done. So now that referral is actually out on the platform, and it's just been updated in real time. The new client file has been recorded, everything's been updated, and you'll be able to get full insight into that client care journey going forward.
Jason, question that I want to make sure I'm not answering incorrectly. It said, can we initiate calls and text messages from inside the platform?
Yes. So you go here to client, you go to right there. Now you can actually log calls, you can actually message them right here. If they have their phone number in it, you can actually text them right from their client profile here. And we're also working to do things like set up appointment reminders as well on the platform to give you that full connectivity to your clients. And in the interest of time, I'm just going to show you some of the initial data that everyone's going to have access to. You go to reports, you could actually go to this demo network here, and you're able to see the breakdown of the individuals on the network. So we can see gender, we can see the age, we can see the ethnicity. We can also see the race, and we can even see how they stack on each other. But what I always pay attention to are the services being rendered. So what are people looking for on the platform? And this is a great sample size to be able to see what your community needs as we go forward. So here we're able to see like parent service type. If you go over to employment, you're able to click on that. Then you can see specifically with employment, what are people looking for? We notice career skills development, we notice job training, and we notice job search and placement. So all this information is going to help us plug in those resource gaps in our communities. And we can even see how the closed cases are doing based off of the different things people are asking for. So are these actually getting resolved? Here we have food assistance is being resolved at a very high rate, but it's also one of the highest unresolved too. So this is all insight that you can actually take and use when addressing the different needs within your communities. Finally, you own all of your information. So you're able to actually go and export it. If you want to see, for example, how many referrals you made over the last 30 days, all you have to do is go to New Export, go to Referrals, Date Range, and Save. And now you're going to get that report in a CSV or Excel file that you can kind of do what you want with it and prove your actual impact.
Question here, and maybe you already answered this. Can reporting be specific to a program as well? I'm assuming meaning like a specific type of program or delivery option.
Yeah, within organization, we can actually do that. We can separate that information out.
Stephanie, if that didn't answer your question, please feel free to drop something else into the chat.
Yeah.
And then it says here, is there a subcategory for perinatal assistance so that support related to maternal infant health can be quantified?
Oh, that is a very good question. We can look into that. I can actually follow up with you about that later if we can break that down.
Because there's basically what we do. Maybe Jason, this is a good way to talk about service types.
Well, yeah, we have the general service types, the parent ones. So under that, we will probably have a maternal health service type and everything. I don't know off the top of my head if we have the specific service type there, but I can actually see. Let's go to network. Actually, let's go to dashboard. We can actually search and look for the different ones, and I can actually show you right there from my network all the different service types. So if you're looking for maternal individual support programs, we can go here and actually find all the different things there. So we have mental behavioral health, all that's under there, physical health, medical wellness percentages. We can actually go and so many different ones right there. And I will then go to make sure that we actually have this particular one, but I will look it up and get back to you.
So Lauren asked if there's a parent-facing interface. Lauren, to the best of my knowledge, that is something that we have done sort of episodically or in specific engagement. So like I mentioned in Sarasota, there already was a parent portal that was built out. We worked to embed with that existing parent portal that they had built. Our platform right now is on the back end. So it's all of the community-based organizations, healthcare providers, et cetera. We do not have, for Unite Us globally, a patient-centered approach. So a patient or a consumer can't just say, hey, I need housing assistance, let me figure it out. What they had done in Sarasota is they already had created this parent sort of educational portal. And then we included in that a request for assistance for us. So it was a little bit different in that example in Sarasota. We're always very open to figuring out what those collaboration points can be. So if there's a state or a county or a city has already created something that it's using to engage, we're always open to discussing like, how do we better embed our work into that? And that was how the Sarasota example that I highlighted came to be. They already had this educational tool and portal for parents that we added to, but they had already created that portal itself. I think that's all of the questions that have come through in the Q&A feature and in the chat. And I think we're at time. I'm not totally sure, Shannon, if we have.
Yeah, I mean, we have a little bit of flexibility. So if there are still questions, I think this is a good opportunity. But I also don't want to, we might be at questions. So I think if you guys want to provide your email addresses in the chat, if there's any additional questions that may come up, or if either one of you are able to stay on for maybe, 5-10 minutes into the next presentation, in case any come through, I think that would be beneficial. If that works.
Yeah, I dropped mine into the chat already, and I think I have some time as well, so I can hang out here.
Okay.
If there are additional questions that folks have for us.
All right. Well, thank you very much for your time today, both you, Jason, and Jackie. I appreciate it. So thank you.
Thanks so much.
Yeah.
One thing that wasn't a question, but was more of a statement, is Elaine mentioned that they're at the Alexandria Health Department, and that Unitas has done trainings, webinars, and supports for the involved agencies. So that was just a comment that came through. But I do want to make it really clear, it's not like we just bring organizations on and then cut you loose and say, figure this out on your own. A lot of what the team on the ground does is work to make sure that the community-based organizations and all of the organizations in the network are comfortable, are adept, feel good about using the tool. I have been on the receiving end, in a clinical setting of like, here's one more thing we have to do. And so we strive really hard to make this as seamless and as easy for all of the users as possible, and are happy to do, like webinars, even perhaps in person. If you have a all hands or an all staff meeting, we can come in and do in-person trainings and the like. So really, Jason and his team are the experts in this, but really try to make it as easy as possible for folks to be able to use it and to get the benefit of it.
Excellent. Thank you again for your time today. So I'm going to introduce our next speaker is Ashlyn Baker. She is with the Human Milk Banking in Virginia at the King's, I'm going to say this wrong, the King's Daughter Milk Bank. So Ashlyn, do you want to go ahead and share your screen?
Yes, let me see about that. Okay, let's see. Are you able to see the PowerPoint?
I am.
Excellent. Thank you so much. Thank you for this opportunity to speak in such a powerful group here in the Commonwealth, working hard on eliminating disparities and improving health outcomes for women, infants, and family in general. So I am excited to share more about our state's first and only not-for-profit milk bank, and hoping that we recruit a few advocates along the way, answer any questions about safety, and share this resource that can be used in the community to help the families, but also, bringing more families to the milk bank and sharing the health with other babies in need. So today I would like to briefly discuss, briefly discuss the benefits of human milk nutrition. I'm not going to go into great detail about that. I feel like you may all be experts here in knowing those benefits. We're going to talk about the reach of the milk bank here in Virginia, talk about safety and quality procedures in both donor screening and milk processing and handling, and then talk about distribution of pasteurized donor human milk. So benefits of human milk nutrition. Human milk is far beyond just a form of feeding or a form of nutrition. It goes farther than macronutrients. It's actually a life-saving species-specific form of nutrition. In March 2012, the American Academy of Pediatrics released a policy statement on breastfeeding and the use of human milk. They stated that given the short and long-term medical advantages of breastfeeding, infant nutrition should be considered a public health issue and not only a lifestyle choice. The American Academy of Pediatrics went on to recommend exclusive breastfeeding for the first 6 months, followed by continued breastfeeding as foods are introduced, with continued breastfeeding to at least 1 year of age or longer as mutually desired by mom and baby. We know the World Health Organization goes on to recommend breastfeeding for the first 2 years of life. As I've mentioned, it's much more than nutrition. Our species milk is both a acute and chronic disease preventer. The disease prevention not only impacts infants through infancy and childhood, but the benefits of exposure to a human milk diet actually follow them through adulthood in reducing diseases that plague our nation and our economy. These are just a few of the reduced infant risk that the American Academy of Pediatrics compiled in their 2012 statement. But this list is ever growing, and there's still so much the benefits are still being found daily, and the different cytokines and the different human milk oligosaccharides and the different components of human milk are continuing to find medical advantages each and every day. We know that breastfeeding is not only beneficial for baby, but lactation is very beneficial for mothers. We know that hypertension, heart disease, diabetes, obesity, cancer, these are diseases that are really locking our healthcare system. You know, it's plaguing the nation, as I mentioned earlier in the statement. And really, it's really remarkable that the feeding that you choose and that you provide your infant at birth and through infancy is going to impact that health through adulthood. So mothers who are lactating are actually reducing their risk of these diseases. So it's beneficial not only to baby, it's beneficial to the economy, it's also beneficial to mother. Thinking about mothers who have pregnancy-induced hypertension, gestational diabetes, we know that they're at high risk for going on to develop diabetes. Through lactating and providing milk, whether it's at the breast or expressing milk and bottle feeding their baby, they're actually preventing these risk factors and protecting their bodies. We also know that breastfeeding is linked to lower rates of abuse and neglect, as well as postpartum anxiety and depression. Economically, we know that approximately $13 billion a year could be saved if 90% of mothers breastfed their babies exclusively for the first 6 months. This $13 billion doesn't include additional cost savings for reduction in parental absenteeism from work. We know that babies that are breastfed or provided a human milk diet, they have less sick days, which means parents are taking less days off work. And as I mentioned, the benefits of exposure to a human milk diet as an infant protects you from diseases that are diagnosed into adulthood. So very important for our economy, not only from an economical standpoint, but from our carbon footprint as well. You know, human milk is readily available, and breastfeeding is a resource that each and every baby may and should have access to. But what do you do when mother's own milk is unavailable? And that's where pasteurized donor human milk comes in. Again, I will refer to this American Academy of Pediatrics policy statement multiple times throughout this presentation, but I also want to note that this statement was reaffirmed again in 2017. And most recently, last month, there was a new affirmation or reaffirmation of this statement through the feeding of VLBWs, which was released by the AAP. So the potential benefits, the potent benefits of human milk are such that all preterm infants should receive mother's own milk. Mother's own milk, fresh or frozen, should be the primary diet. And if mother's own milk is unavailable despite significant lactation support, then pasteurized donor human milk should be used. This statement became a gold standard in hospitals across the country. Milk banks rapidly saw an increase in demand for the need for pasteurized donor human milk once the American Academy of Pediatrics said, released this and said it so boldly. And this was a very exciting time for breastfeeding as well, because just bringing on pasteurized donor human milk into the NICUs and to the units, it required healthcare providers to consent for treatment, which means in the midst of stabilizing premature and critically ill babies, providers needed to stop and talk about the benefits of a human milk diet, the benefits of breastfeeding. So it also was a huge increase in advocacy efforts for supporting mother's own milk feedings in the NICU, as more families were becoming even more aware of the benefits of human milk, that they were deciding that, wow, it's so important that, you know, this physician is talking to me about using pasteurized donor human milk. Well, you know what? I just gave birth to a 23-weeker. I wasn't sure if I was going to provide milk or not, but let me start pumping for my baby and let me start providing. So it not only led to an increase in the need for pasteurized donor human milk, and more banks were established, but it also started to send critical messages to families about mother's own milk for their babies. We know that human milk has life-saving benefits, and we talked about the benefits such as like autoimmune or asthma, allergies, diabetes, obesity, ear infections, But for the NICU baby, the high-risk premature infant in the NICU, we know that a human milk diet is going to decrease the risk of necrotizing enterocolitis, which we refer to as NEC. And NEC is the leading cause of death for premature infants in the NICU, secondary to prematurity. We know that a human milk diet is going to reduce the risk of necrotizing enterocolitis by as much as 80%. Ethically knowing that, and we'll talk about challenges and access to donor milk concerns and issues. How can we walk to the bedside of a extremely low birth weight infant or a very low birth weight infant on life support and provide formula knowing that it's going to increase the risk as much, as I mentioned, as much as 80%. We know that a human milk diet is going to reduce the risk of sepsis, mortality and morbidity rates are going to decrease, feeding intolerance is going to decrease as well. So, species-specific nutrition is much easier. A human milk diet is much easier for these infants to digest than providing them with artificial infant formula feedings. We know that when they're tolerating feedings, you're going to advance on feeding volumes. You may not need parental nutrition as long. Parental nutrition runs anywhere from $500 to $1,000 a day for that IV parental nutrition. If they're tolerating human milk feedings, then they're going to get less parental nutrition. Their line days, sepsis rates related to bloodstream infections from central lines. If they're tolerating feeds, they're advancing feeds, their line days are shortened, which also shortens or decreases their risk of sepsis from bloodstream infection. So human milk directly impacts their feeding tolerance and their advancing in feeds and need for IV access and other forms of artificial nutrition. Length of stay has been shown to be reduced as well as readmission rates after discharge. And severe retinopathy of prematurity, I can't say it enough, human milk is much more than nutrition. It's remarkable that our own species milk is directly related to a reduced risk of severe retinopathy of prematurity, the leading cause of blindness in premature infants. And chronic lung disease as well. So this form of nutrition, is literally like a medicine for these babies. In 2011, the Surgeon General called Action 12, which was to identify and address obstacles to the greater availability of safe banked donor milk for fragile infants. To this day, we're still fighting this battle. We're trying to get access to these babies, regardless of their ability to pay, regardless of their zip code, regardless of where they're located, what size the infant is. If the baby is in the ICU, the baby has a medical need, we need to address these obstacles and to get this milk to these infants, preferably mother's own milk. But if mother's own milk is not available, we need to get pasteurized donor human milk to these infants to prevent death and to prevent those adverse outcomes that comes along with being critically ill or born prematurely. In 2017, the AAP Committee of Nutrition in the section of breastfeeding and the Committee on Fetus and Newborn Health also stated the same. They said that donor milk for high-risk infants should not be limited to the families or individuals' ability to pay, and that policies are needed to provide high-risk infants access to donor milk based on the medical necessity and not the financial need. And I will say the state of Virginia, the Commonwealth and General Assembly the last few years, we have been working on several different House bills and Senate bills that would cover pasteurized donor human milk for high-risk infants. And then there's, we'll talk more about policies here shortly, but also the need for outpatient access to pasteurized donor human milk for high-risk infants in the home to keep them home with their families and decrease their risk of readmission to the hospital. So with all that we've talked about, the benefits of a human milk diet, why and when you use pasteurized donor human milk, which would be when mother's own milk is unavailable, especially for medically fragile infants and high-risk infants. But let's talk a little bit more about safety. When you're talking about the use of pasteurized donor human milk, I want you to be very confident and knowledgeable about the history and the differences between the different entities and the donor screening processes. Oh, I'm not sure, I think my screen, oh, there we go. Okay, so I'd like to spend a little bit of time talking about safety and quality. Since the founding of the Human Milk Banking Association in North America in 1985, we're proud to report there has never been an incident of disease transmission or negative outcomes to an infant due to the processing or distribution of pasteurized donor human milk. Again, the AAP stated that donor milk banks represent a safe and effective approach to dispensing human milk for NICUs and other settings. And they also reassured families and caregivers that there have been no reported cases of pasteurized donor human milk causing an infection, and the likelihood of this happening is extremely small. In fact, I quote the American Academy of Pediatrics a lot throughout this presentation, but there are organizations throughout our country and actually internationally that have position statements that specifically support the use of pasteurized donor human milk. So it's not just the AAP's effort, it's not just HMBANA, the Human Milk Banking Association in North America. There are a long list. This is just a few of a list of organizations that are aware of the benefits of a human milk diet for babies, and aware that when mother's own milk is unavailable, especially for the high-risk infants, that pasteurized donor human milk is the next best option. And please note that I'm using pasteurized in these statements, and also note that the quotes that we're discussing are about pasteurized donor human milk and not sterilized. That's a different type of, a different technique that still warrants further research. In 2017, the American Academy of Pediatrics said that sterilized donor human milk needs further study. So I will state that all of the evidence, all of the research, all the position statements, all the support is in the use of pasteurized donor human milk when a mother's own milk is unavailable. HMBANA is our nation's only professional accreditation association for milk banking. They lead the industry in quality and safety, both nationally and internationally. And our guidelines, that HMBANA accredited milk banks guidelines, are modeled almost identically to the blood banking industry. We work very closely with the blood banking industry. We also work very closely with the CDC and the FDA. HMBANA's guidelines, again, evidence-based, and they were written under the advisement of the CDC and the FDA. Both the FDA and the CDC recommend HMBANA accredited milk banks for families that A, are in need of safe banked donor milk, or B, have a surplus of milk and want to donate their extra milk. So if you were to go to the FDA's website, you will note that they will recommend HMBANA accredited milk banks for safe access to donor milk. So currently, this photo is a little dated. There are actually 31 not-for-profit milk banks in North America, and the King's Daughters Milk Bank here in Norfolk, Virginia was established in 2014. And I'm going to jump into telling you a little bit more about our history. First, because we are virtual and I would love to bring everyone here for a tour of the milk bank, I'm going to show you a brief video just to kind of give you some insight into our state's nonprofit milk bank.
The King's Daughters Milk Bank is operated by Children's Hospital of the King's Daughters, a full-service, freestanding children's hospital. We are nonprofit and proud to be accredited by HMBANA, the Human Milk Banking Association of North America. To ensure the safety and quality of our milk, we adhere to HMBANA's rigorous, evidence-based guidelines for donor screening and milk processing. Each week, pre-screened donors from all over the country send us thousands of ounces of milk to pasteurize and deliver to medically fragile infants. After completing careful processing and quality assurance protocols, our treatments are shipped to neonatal intensive care units in hospitals throughout the United States. When milk supply allows, we also fill prescriptions for pasteurized donor human milk treatments for infants and children with medical needs in the home. In our first 5 years of operation, we received more than 1.5 million ounces of life-saving human milk from our generous donors. From donor screening to milk processing and pasteurization to packing and shipping, the King's Daughters Milk Bank delivers high-quality human milk treatments to infants in need. Your breast milk can save lives. To learn more about obtaining
All right, so just a little visual. With only 31 milk banks in North America, seeing one firsthand is always very exciting. And once we can get tours back, back up and running, we'd love to bring in guests to visit the milk bank. And everything on this slide was mentioned in that video, but we are very proud to be the 18th out of 31 milk banks in North America. When we opened the milk bank in 2014, there was a lot of doubt about, if milk would come in, would we have enough milk to supply the needs? And we are proud to report that we provide pasteurized donor human milk to over 45 hospitals. Primarily, the milk goes here to infants and children in Virginia, but as supply allows, we extend to states stretching from New Jersey to Florida, as well as outpatient infants in need. Since 2014, we've received over 2.5 million ounces of milk from altruistic, volunteer, non-remunerated donors. We currently serve around 80% of the NICUs in Virginia, and we'll go into a little bit more detail about that in a future slide. We assisted many hospitals in the state and surrounding states with implementation of pasteurized donor human milk treatment protocols. And again, we help infants in the home stay in the home with prescription pasteurized donor human milk. So we might have some short gut babies who've had bowel resections. Maybe they had that devastating disease called NEC, and they're doing really well with pasteurized donor human milk in the home. We have babies awaiting renal transplants on dialysis who are getting donor milk in the home. And we have a lot of very unique cases where pasteurized donor human milk is keeping these families, these babies in the home with their families while they grow and thrive. We work closely with the local Department of Health, with WIC and other organizations to spread the word about the benefits of breastfeeding and the need for milk donation as well. And we serve as a resource center for both medical professionals and the public. We're registered as an FDA food handling facility. The FDA kind of considers this a hybrid. They're unsure really whether to call us food or medicine. So we do try to meet both of those guidelines by becoming a food handling facility and also by being accredited by the Human Milk Banking Association of North America. We have a multidisciplinary staff that's trained rigorously in food safety and CNGMPs. We have a medical team here with nurses, dietitians, lactation consultants, physicians, and then we also have the food safety side as well with the PCQIs and the food safety managers. We have a robust panel of milk bank consultants in a wide variety of areas to support the bank and support the mission. Our donors are the most amazing women and families to work with. They are not location specific, but I will say roughly 80% of our donors are from Virginia, but location is never an issue. Our donors are 100% altruistic volunteer donors. Himbana recommends that all donors are recruited altruistically, meaning they are not paid for their donation. They are giving freely and voluntarily without receiving reimbursement. And we focus on that because that increases safety. Commercial or professional donors that are paid, sometimes altruism takes the back seat when payment is rendered. And we've actually seen some pretty sad cases where families were really looking to make the money and withholding the milk for their baby. So we definitely fully support an altruistic, non-remunerated, 100% volunteer donor recruitment process. And that's what's recommended by the World Health Organization, the FDA, the CDC, the American Association of Blood and Tissue Banking, as well as Himbana. We know that these donors are the lowest risk donor versus compensated donor types. All donors undergo a national screening process that includes medical and social lifestyle questionnaires. They have these questionnaires completed in both a verbal and a written form. All donors must have a written confirmation of health completed by their own baby's pediatrician, as well as their OBGYN. stating that they are in good health, that they do not have any risk factors, that they were negative and non-reactive for disease during pregnancy, and that their providers recommend them as being a good candidate for donation, and that their own baby is growing and thriving on mother's own milk. We definitely do not want to accept milk from a mother whose baby is struggling to hit the growth curves. So we require the confirmation of health for both mom and baby. We also really want to dive into those prenatal pregnancy serologies and review those as well. And also a list of the medications that the provider has on file versus what was reported during the donor screening. In our screening process, that medical and social questionnaire, we ask the same questions in very different ways in both the verbal and written form, just so we can confirm that we're getting the same answers and that we're getting all of the information that we need to decide if this family is going to make an appropriate donor for the milk bank. Drug screening versus milk testing. All applicant donors undergo risk screening for alcohol, nicotine, marijuana, and other substances of abuse using the TAPS1 tool. It's a government validated tool. And the guidelines surrounding drug screening mirror those of blood banking. We have the same exact drug screening guidelines as blood banking industry does. Applicants are usually also feeding their own infant, and that written confirmation of health form alerts us to any known risk factors in the dyad. And I say usually because, and we'll hit on this topic very briefly, some of our donors are bereaved donors who are donating as a legacy for a pregnancy or infant loss. And then we also have families whose babies have cow's milk protein intolerance or other allergies, and maybe they're donating milk that their baby can't tolerate or won't take, maybe because of lipase issues. So sometimes they're donating that while they're rebuilding a new supply on their elimination diet. Additionally, all batches of donor milk are pooled to provide an additional layer of safety. Each pool of donor milk is the milk comprised of at least 5 to 10 mothers, with a total of 500 plus ounces in each pool of milk. So the bottles of donor milk that you receive, it's not the milk from one mother, it's the milk blended of multiple mothers. We blend it for safety, but we also blend it for nutritional balance, and we also blend it for antibody exposure. Each mother is going to release antibodies in her milk, and the more mothers, the broader range of antibody exposure that we can provide to these infants. At present, there's no FDA-approved method for drug testing of breast milk. This is a really critical piece, especially with potential regulation of milk banks at the state level. We are all about regulation by Virginia Department of Health, should that be deemed necessary. But we do have concern that there is not an FDA-approved method for drug testing of milk. And some of the regulation bills that have been proposed have been recommended based on the model of the for-profit industries, the out-of-state for-profit industries who remunerate or pay their donors and have different models and different risk factors. So currently, nationally and internationally, milk banking associations do not require that the milk is tested, but instead they require that the donors are screened. Again, we use the TAPS1 government validated tool. That validated screening questionnaire is also backed by the American Academy of Pediatrics, the American College of Obstetrics, ACOG, and the American Society for Addiction Medicine. There is one kit on the market that's being labeled for drug testing of breast milk, but after spending a lot of time with Dr. Thomas Hale, who writes Medication in Mother's Milk, as well as he's the director of the Infant Risk Center at Texas Tech. We talked to toxicologists throughout the country and throughout the state. This kit specifically is labeled for forensic use only, and it's designed for serum, saliva, and urine. Breast milk is a greatly complex substrate with a very thick fat layer in the foremilk and the hindmilk. These kits are not made for breast milk, and they're not made specifically for drug testing. So drug testing of breast milk. They have no controls, they're not replicable, and they haven't been validated. So that's very concerning that these kits are being marketed And it's something that we are working with experts throughout the state and the nation to, look for other methods, but currently there are no actual methods. There's no methodology that you can refer to at this point. All donors undergo additional serum screening before they're approved as a donor. So we do test all donors for HIV 1 and 2, HTLV 1 and 2, hepatitis B, hepatitis C, and syphilis. So we know that they were negative and non-reactive for disease during pregnancy. We want to know that they're negative and non-reactive for disease during lactation. Finally, our quality assurance team, including our medical director, Dr. Michelle Brenner, reviews all applicant screening records and results for final donor approval. Applicants also receive education in proper hand and pump hygiene, milk collection, storage, and transportation procedures. And approved donors either deliver their frozen donations in person or are provided with prepaid materials and instructions to ship their frozen donations directly to the milk bank. So location is never an issue, and there's never any cost whatsoever to the donor. The milk bank absorbs all costs for donor screening, for delivery of milk donation, processing, and pasteurization. Approved donors have ongoing health screenings with each donation and updated medical and social assessments regularly throughout their tenure as a donor. So it's not a one-time approval for donation. These donors are often making frequent, maybe monthly or every other month, they're making donations, and they have reassessments and screenings with each donation. And I do want to briefly show you a video. This month is Pregnancy and Infant Loss Awareness Month, and I'd like to share, if this will work, just a little excerpt about our program here, raising awareness about options and the potential to donate milk as a legacy after a loss of a son or daughter. Now, lactation after loss isn't something that's for everyone, but it is something that we should be acknowledging, that after a loss, families will leak what we call white tears, and they need to know what they can do, whether that is ceasing milk production, whether if it was a NICU loss and there's freezer full of milk and this mother had a well-established supply, that A, she can donate the milk that she had previously pumped, but B, she needs to slowly wean her breast from producing milk so that she doesn't experience engorgement, mastitis, additional pain and discomfort, all while grieving a tragic loss and preparing for a funeral for her baby. So it's a topic that a lot of times is often overlooked and mismanaged. And hopefully my video is going to work here. And of course, it doesn't look like it is. Okay, well, I'll skip back to that and put the link to the video in the comment section, the chat section after I'm done. But the legacy milk donation support is really important. So emotionally, physically, and spiritually, it's been very healing for our donors to share their experience, whether it's, physically by producing the milk, and by lactating, they're protecting their heart from, hypertension, heart disease. They're preventing obesity, diabetes. They're helping with the involution of their uterus and the decreasing postpartum blood loss. Spiritually, through lactating after a loss, they feel very connected to the mothering and the care of their infant. Just being close to that infant and knowing that the milk that they're producing for their baby, although it couldn't be fed to their baby now, it's going to help their baby's legacy to live on. And I always say it's like footprints, leaving their baby's footprints in NICUs throughout the country. And emotionally, through lactation, they're releasing hormones that help them to naturally combat anxiety and depression. These families really want to talk about their baby. They want to acknowledge their baby. We even have brand new double electric breast pumps and supplies available as needed should a family decide that they want to go on to express milk and donate as a legacy. And we have tokens of appreciation and recognition for their babies. That video, I'm really bummed it's not working because it shows our new memorial, which has pearls with all of the babies' names on it whose families who have donated as a legacy. So stay tuned, I will send you that video. And then let's jump over to processing. So we talked about the benefits of human milk nutrition, why pasteurized donor human milk. We talked about donor screening, but let's briefly talk about processing of donor milk. So all donor milk is thawed, strained, pooled, and dispensed into BPA-free polypropylene bottles, and all bottles are sealed with tamper-evident seals and labeled according to FDA regulations. All donor human milk is processed by the Holder method of pasteurization. The required time and temperature profiles are defined by the FDA and Humana to ensure destruction of pathogens, including but not limited to SARS-CoV-2, Ebola, Marburg, Zika, CMV, HPV, and HIV. Interesting, this does come up often, as it should. Questions, how do we know that, COVID can't be passed, the virus can't be passed through human milk? Well, there are two studies. There's been multiple studies. This is just two that I'm highlighting, where human milk was inoculated with high levels of SARS-CoV-2 virus, stimulating the theoretical worst case scenario. The samples were pasteurized using the Holder method and the virus was completely inactivated by pasteurization. Again, there was another study by Unger and her team who showed that pasteurization, again, inactivated the SARS-CoV-2 virus. So we are confident that our donors are already deferred for illness. They're deferred from donating for 2 weeks prior to the onset of their COVID infection if they became infected. They're deferred during their entire infection period, and they're deferred for an additional 2 weeks after completely recovering from the infection. So we have a significant deferral process that's above and beyond the national guidelines. And then again, we also have the Holder method of pasteurization, which has been shown in multiple studies to inactivate the virus. A bottle from each pasteurization, each batch of pasteurized donor human milk goes to the microbiology lab here at the hospital, where it's tested for an aerobic count of Bacillus, E. coli, Salmonella, Pseudomonas, Staph aureus, yeast, and mold using the most advanced microbiological identification system available, which is called MALDI-TOF. So all pasteurized donor human milk is not only cultured, it's been heat treated, it's been cultured. We're also going to perform nutritional analysis. So you know that you're getting a hospital grade human milk with plenty of energy and calories and protein for high risk infants to grow and thrive. And then we also review all of the records, the nutritional analysis, the cultural reports, the pasteurization reports, the donor approval reports, prior to approving and releasing the donor milk for dispensation. So donor milk is dispensed by prescription or hospital order, and each bottle is required to have an FDA compliant label with an identification barcode to be scanned at dispensation. We maintain a very strict system of tracking and recall at all times, and we ship all pasteurized donor human milk, which is frozen, via priority overnight shipping with dry ice and cold chain verification. In Virginia, like I said earlier, about 78% of the donations come from Virginia residents. Also, roughly 80% of our donors are working mothers, which says a lot about breastfeeding in the workplace and supporting pumped breaks for families who are expressing milk. Over 80% of Virginia level 2 special care nurseries and level 3 special care subspecialty NICUs receive donor milk from our milk bank. We also serve several newborn nurseries who offer donor milk supplementation while breastfeeding is being established. So they're using it as a bridge, helping them to meet like the Joint Commission, PCO5 core measures, reaching Healthy People 2030 goals, which is increasing the amount of babies exclusively breastfeeding at 6 months of age, and helping to reach baby-friendly initiatives. Again, earlier I mentioned just the process of consenting and discussing the use of pasteurized donor human milk actually increases mother's own milk rates. So the conversation and just having it present is actually increasing rates of breastfeeding here in the state. Some of these families are going home with very small amounts of pasteurized donor human milk as a bridge while working on the latch and while working on establishing mom's milk supply. So we're evaluating the family's desire to exclusively breastfeed their infants, and the feedback that the families are reporting for hospitals that are providing access to banked milk is really astonishing. They are so very thankful that the hospital has supported their desire to breastfeed their baby and to offer human milk species-specific diet from the first feeding. And again, we provide donor milk on an outpatient basis by prescription. In fiscal year 20, we distributed around 215,000 ounces to hospitals, of which 66% of that went to Virginia hospitals. And that year we distributed around 72,000 ounces of donor milk to outpatients, with roughly 76% of that going to Virginia infants in the home. Coverage challenges. Our primary goal, of course, is to support mother's own milk feedings. So any type of support that is going to increase the amount of families breastfeeding and expressing and providing milk to their babies is our goal. Secondary is, we really have to work on, we need help and we need advocacy in increasing access to pasteurized donor human milk when mother's own milk is unavailable. Hospitals are covering the processing fees for the non-for-profit processing fees for donor milk, but also some hospitals do obtain their donor milk from for-profit milk banks at much, much higher fees. But the hospitals are covering these fees regardless for their highest risk infants as a standard of care, and they're not being reimbursed for that coverage. They know firsthand how devastating NEC is, how devastating sepsis can be for these infants. And they also are following the recommendations from the American Academy of Pediatrics. But access is limited despite known benefits, and that's really due to lack of coverage. There are some hospitals in certain zip codes, and the CDC has a Disparities article on this, that based on the zip code, the hospitals safety net hospitals aren't able to cover the processing fees and provide these donor milk treatments to infants, especially without insurance reimbursement. So insurance coverage is critical so that all infants with medical need have access to pasteurized donor human milk, despite their zip code, despite insurance, despite, where they're located. We really need to make sure that the hospitals have the support they need to ensure that they can provide these treatments to the smallest, highest risk infants. So donor milk is not covered by pretty much any insurance but TRICARE. TRICARE only covers it on an outpatient basis for infants with a medical need. So this is a big struggle, but it's something that General Assembly, the last few years, it's been a hot topic. The support from hospitals throughout the state has been huge. You will probably hear from us again this year. We really need to work together for coverage. First and foremost, coverage for pasteurized donor human milk. The fortifier, human milk fortifier is great, but when you lump the processing fee for pasteurized donor human milk and the fee for human milk fortifier, it makes it harder for us to get at least one covered, which would be the standard of care, which is pasteurized donor human milk. So when I look at some of the sister banks, other states and how much it costs, the state to provide access to pasteurized donor human milk versus to provide the fortifier, we need to move in stages. We need to get coverage for pasteurized donor human milk. Yes, human milk fortifier coverage is very important as well, but I'm not sure that they should be linked into the same coverage bill. But that's something I'd love for others to reach out, and we can discuss further on how to best advocate for at least coverage in donor milk and moving towards coverage for fortifier as well. Share the health. This is one thing I'm going to close on is, we as our state's only non-for-profit milk bank always need help in recruiting donors. If you're working with families who have a supply and surplus of their baby's needs above and beyond their baby's needs, their freezers are busting at the seams, it's always a wonderful opportunity to share the health and mention the opportunity to donate milk and help feed other high-risk infants throughout the Commonwealth and throughout our nation. We have brochures and rack cards that can be used in your practice, in your units, or at events that you're hosting, but really together we can collaborate, we can advocate, and we can remove obstacles to access. Not only are we asking that you would be an advocate in donor recruitment, but you can also send your families to us that need help, and we can see what we can do. Without coverage, we are quite limited on what we can do on a charitable care or community benefits level. So coverage is going to be a huge advocacy effort that we need your help with, so that, as a not-for-profit bank, we can ensure that we can fill the needs as the second best option. And hopefully, donor milk is being used as a bridge, and moms are working on, or families are working on their own milk supply, but together we can collaborate, we can advocate, and we can remove these obstacles. We value your dedication to reducing both maternal and infant mortality and morbidities. And we'd really like to extend our partnership and collaboration with interested parties, with healthcare providers, anyone who wants to work on ensuring safe and ethical milk banking standards are maintained here in our Commonwealth and truly nationally. But also, let's improve access to donor milk for disadvantaged and fragile communities for all. So thank you so much for your time. Hopefully you learned a little bit about our state's milk bank. I can answer any questions that you may have. But again, here's my email address. Please email me with any ideas, suggestions, questions, collaborations. I look forward to hearing from you.
Thank you, Ashlyn, very much. We do have about 3 minutes for questions. One question is, how much does it cost to use human milk banks?
Yes, so the not-for-profit processing fee for donor milk is $4.50 per ounce. Again, not covered by insurance. That covers the donor screening, the blood testing, the physician approvals, the shipping of the frozen milk, the processing and pasteurization, the culturing, the analysis. This is the fee that ensures the safe product is ready to go and readily available for infants in need. TRICARE, as I mentioned, is the only insurer that will cover on an outpatient basis, but hospitals are covering the processing fees as a gold standard despite lack of coverage. They consider it a gold standard. They're not charging the families for it in the hospital, and they are not being, again, reimbursed by insurance. Just to give you an example, the for-profit out-of-state entities or out-of-state milk banks, they charge anywhere from $12 to $16 per ounce.
Okay, thank you. And Jackie asked, do you provide a support group or forum for mothers?
So currently we do not provide a support group for mothers. We'd like to have a support group, especially for our legacy donors. And that is something that's on our agenda in an area that we hope to grow. But currently donors communicate directly with the milk bank. We don't have like a social media group for them. Being a hospital-based milk bank has a lot of benefits, but it does make it a little bit more challenging to have our own social media presence. We do feel strongly that a hospital-based milk bank has additional safety and risk management mitigations in place, which we're very thankful for. But again, from the social media presence, we're still underneath the hospital umbrella, so we don't have our own individual presence there, which again is why we're always asking for advocates to help spread the word as well. We do require, lean heavily on our milk bank donors who retire as our ambassadors to spread the word, but also our advocates to help spread the word about the option to donate milk. I will say to date, 8 years we've been established, or going into our 8th year, we've never been unable to fill a hospital order. We've never been unable to meet the needs of the Commonwealth's donor milk needs, but we do need help so that we can reach more infants, especially on an outpatient basis. But we also need our hospitals throughout the state need support and coverage for pasteurized donor given milk.
Thank you. And one last question, and you touched on this briefly, but I don't know if you want to add anything. How are most of your milk donors obtained? And the question is referrals.
Yes. So we've done a lot of unique educational opportunities and events to spread the word and to raise awareness amongst healthcare providers. So you guys are really our first line of advocacy because you're working hand in hand with these families and can share the opportunity to donate. Prior to COVID, we would obviously be out at all parenting events and breastfeeding supportive events as well. Any opportunity we could to get in front of families and healthcare providers to spread the word. A lot of people ask, how did COVID impact milk donation? And I would say there are a couple things I'll briefly say about that is we had more donations come in than we have ever experienced throughout the pandemic. Families were home, and while I want to say breastfeeding was protected, you know, a lot of families were able to work from home and were able to directly breastfeed their babies and didn't have a great need for the frozen milk that they had stockpiled in their freezers for when they returned back to the workplace. So we did have a lot of families interested in donating that milk. But on the other hand, it's been very difficult for new families that need breastfeeding help to feel isolated and being unable to get that support. But I will say throughout the pandemic, it has been a very positive experience in milk donation. Families have said that this was one way that they could fight the pandemic from home by helping to feed preemies and other babies in need.
Excellent. Thank you again, Ashlyn, for your presentation today. All right, so moving along, our next presenter is going to be Lieutenant Ashlyn Smith, who is in the Medical Corps with the United States Army. And then also we have our own Dr. Margaret Villers, who's a maternal fetal medicine provider at Mary Washington. And let me pull up the slides. All right, welcome and thank you. Hello, good morning. Can you guys hear me? No, not very good. Not very well. Okay, let me see if I can increase the volume. Are you able to hear me better now? If you're closer to the mic, we can hear you. Okay, so is this, can you hear me at this? We can hear you. They can turn, if you guys are having a hard time, if you can turn your volume up on your computer. Okay. So good morning and thank you for having me here today to present. I'm Dr. Alicia Smith. I am currently one of 2 OBGYNs providing care for the Afghan guests at Camp Upshur in Quantico, Virginia. Dr. Joy Greer actually is another OBGYN at Camp Upshur.
Dr. Smith, I'm sorry, a lot of people can't hear you. Where your voice is very low.
Are you able to hear me a little bit better?
It's still difficult. It sounds, maybe try again.
Hello, are you able to hear me?
And then it's all you.
Thanks, Shannon. Can you remind me, Shannon, just about, I know that we're about 20 minutes past the hour. Just tell me how much time I have for the presentation and questions.
You're good with 45 minutes. Actually, there's nothing after you, so we can run with however long you want.
All right, sounds good. Well, thanks so much, everybody, for joining in today. My name is Dr. Rishi Manchanda. I'm CEO at Health Begins. I am a primary care and public health trained physician, and I've spent the bulk of my career working with marginalized populations and communities. So I spent 4 years as part of the National Health Service Corps at an FQHC in South Central Los Angeles, providing primary care, developing programs to address social needs for patients. I spent another 4 years caring for homeless veterans, again, here in Los Angeles, where I live, for the VA system. Again, building programs to help improve outcomes, both health and housing outcomes for homeless veterans. And then I spent a couple of years as the chief medical officer for a large self-insured employer with about 10,000 farm workers under their employment in the Central Valley of California, building up clinics and programs there. So I've spent the bulk of my career as a clinician and have had the privilege of having various administrative and executive responsibilities. A big through line for my entire experience has been this, this awareness and growing kind of expertise and improving outcomes, especially the quadruple aim for patient populations that I've had the privilege of serving, by being able to move upstream. And I'll tell you a little bit more about what that work means, especially in the context of what I've been asked to talk about today, which is Health Begins work supporting a maternal health collaborative in Virginia. So let me share a screen here. Hopefully you can see my screen. So the Maternal Health Upstream Learning Collaborative is something I wanted to share with you all today, and to talk a little bit about why the story I just shared with you, my own personal story, is related to kind of this work. By the end of this session, I'm hoping that you'll be able to better describe what we call the social and structural drivers of health equity and why they matter to healthcare, particularly maternal health. And also, we hope that you'll be able to list some of the steps from what we call the upstream approach that many of the teams in this learning collaborative across the state are taking to improve health equity outcomes for maternal health. So with that in mind, let me give you a brief primer. Some of you may know this already, some of you might be participating in this, but with generous support from VNPC and from VHHA and VDH to a certain extent as well, we are convening and supporting 7 teams from across the state in this maternal health upstream learning collaborative. Health Begins is a facilitator of this work. It's consistent with our work, I should say. Health Begins started this organization several years ago to help many healthcare partners move upstream to be able to address social and structural drivers. We are a mission-driven national consulting firm and a training firm, and this work has been, this work with the Maternal Health Upstream Learning Collaborative has been an extension of some really wonderful opportunities that we've had to work alongside partners in the state, across the state in Virginia. The teams that we're working with in this collaborative are working to address the upstream drivers of maternal health inequities, and they're doing this by designing what we call upstream quality improvement or upstream QI campaigns. I'll tell you more about what that looks like in a minute. The overall aim of this collaborative is really informed by the work of the funders who have underwritten this work. The VDH Office of Child and Family Health, the VNPC, of course, and the VHHA Foundation all seek to improve maternal health disparities within the Commonwealth. This is in support of the governor's goal to decrease the number of deaths and pregnancy, childbirth, and post-pregnancy related deaths among mothers in Virginia, and particularly among African-American mothers in Virginia. So therefore, this particular collaborative is geared to help health systems and clinicians within them to be able to undertake quality improvement projects to help address the drivers of these inequities, specifically the structural and social drivers of these inequities that we're seeing. And to, as part of that process, learn the value of this upstream approach. Again, I'll go into that in a second. When we were asked to help convene and facilitate this, this particular chapter of this learning collaborative, we were asked to kind of outline what the benefits are. What's in it for me, essentially, is the question we were trying to make sure we answered for participants. The first benefit is that for teams who are participating, we're hoping that they'll be able to better identify inequities and opportunities for improvement using data analytics opportunities that come from VHHA, as well as their own internal data analytics and community health kind of information. We also hope that they'll be able to improve the capacity to better address social needs that patients experience, that their patients experience, and that those social needs that often drive inequities. I'll give you an example of what that looks like. And we also hope that the teams that participate in this collaborative, much like with all the other learning collaboratives that Health Begins runs across the country, including within Virginia, that participants will be able to identify concrete opportunities to help improve the social and the structural drivers. And again, this is through this upstream quality improvement approach. When we started with this project and facilitating this, we asked members of the teams from across the state, 7 teams, 7 different health systems, to be able to identify what existing work they're already doing, what those priorities already are when it comes to maternal health outcomes. So we know many of them have participated or are currently participating in QI initiatives, including those that VNPC organizes. We also asked them about whether their system is also already screening for social needs. We know that there is a scale up of a platform in the state to better connect patients to resources, those patients who have unmet social needs, like food insecurity or housing instability, for example, to appropriate resources. And our question was, to what extent our system is already screening many patients, including birthing people, for those. We've also wanted to understand to the extent to which many of the teams and the system specifically already have partners in the community, including CBOs or community-based organizations, to help address those unmet needs, perhaps using some of the technology platforms, the referral platforms that are scaling up in the state. So I've said a lot of words here about what we're trying to do, but let me kind of tell a story instead and try to draw down a really concrete understanding of why this work matters and how we're grounding this work in the collaborative itself. Let me tell you about a patient named Michelle. Michelle is 5 months pregnant with her second child. Her first child was born by a C-section due to elevated blood pressure about 18 months ago. She recently moved to a community within your service area, meaning this is a case study we've given to teams in our collaborative. So we say to teams, imagine Michelle has now moved to a community that you serve in your health system, and she's being cared for by a clinic in your health system. Michelle in this new neighborhood doesn't have much family or support. She's trying to make connections. Finding childcare she's found can be challenging and stressful, especially because her job doesn't give her consistent pay, let alone high enough pay, but also more importantly, consistent hours, especially since the pandemic. She experiences mild hypertension and gestational diabetes. Anyway, last week while she was at work, coworkers got really concerned. They called the paramedics because they noticed that she was feeling really faint, about to pass out, and she was admitted to the hospital for observation. And again, we framed this story as we talked to the teams participating to say, well, she's admitted to your hospital to create a sense of ownership here. So let's think about Michelle, this story, and use this as a kind of grounding to describe what we do in the collaborative. Part of the reason we share this story, and I want to share it with you guys today, is to help ground you in what we mean by moving upstream. We know in hospitals that we're very well trained, and we expect that our caregivers are able to identify biological possibilities, root causes in what's happening within our bodies, right? Whether there's an underlying infection, for example, or there's elevation in blood pressure, or some interaction of medications that might have led to Michelle's problems of nearly fainting. So we're trained to look at those things with rigor. We have a battery of tests and standards that we use to be able to quickly identify potential biological causes. Increasingly, of course, in healthcare, we're getting better at looking at behavioral issues as well, not just biological. So to what extent is this an unmasking of an underlying depression, or are there other complicating factors in stress? In other words, how she's eating, sleeping, caring for herself, caring for her kids, how she's managing her health and her pregnancy in particular. Those biological and behavioral causes are things that we are getting better at, biological certainly, and even with behavioral, we're getting better at looking at these things with rigor. What I posit and what we know across the country based on the evidence is that health systems in general haven't have yet to go a long way when it comes to improving the rigor to address not just the biological and behavioral, but the social factors. So for example, food insecurity. To what extent are we routinely expecting and routinely seeing in practice the screening for social conditions, not just how she's eating, but whether she's eating, whether there's enough to eat that's healthy, as well as other living and working conditions like housing instability or transportation or other unmet needs. And to what extent even further are we actually looking at the deeper factors that shape food insecurity, for example, as well as the behavioral and biological, and that includes looking at structural and institutionalized racism as well. My point is, we in healthcare have come a long way, but we have a ways to go when it comes to truly, with rigor, understanding the potential root causes, the potential drivers of this poor outcome for Michelle. And that's part of the journey for all of us, including the Learning Collaborative. And this is important because in this case, it was food insecurity that was the driver for Michelle's hospitalization. Food insecurity is, for patient populations in general, a poor predictor of, for adults in particular, a predictor of poor outcomes and utilization, both in terms of increasing IP or inpatient visits, as you can see, all of which are very costly and potentially avoidable, as well as on the right, multiple ER visits in the course of a year. The national data, as well as data in Virginia, now tells us that food insecurity, among many other social needs, is a major predictor of poor outcomes and preventable utilization, especially inpatient utilization. It's important to note that food insecurity itself has also, in the context of pregnancy, been linked with gestational diabetes, iron deficiency, low birth weight. And so these social conditions actually really matter, right, for us to be able to understand, because it has an impact on Michelle's health and the health of patients across the state. In this context, I've been using, we talk a lot about social factors, but one of the things that we found in healthcare is that many are still conflating terms, and that often impedes the ability to apply a rigorous approach to doing this work well. What I mean is, you hear the term social determinants of health in healthcare these days, but we actually hear that being misapplied. And I'll explain why it's so important to be rigorous with the ways we use these terms. Michelle, for example, and her family experienced food insecurity as a household level phenomenon. That's a social need for her as an individual and as a family. That's a social need, or in the context of healthcare, a social risk. That social need is both the driver and also a sequelae, a consequence of health inequities. And the reason that makes sense that it's a social need is because Michelle and her family, as with other families in her neighborhood, live in a food desert. That food desert is a community social determinant of health. The term social determinant of health has actually been defined for almost 40 years in the public health literature as a set of conditions that are often defined by geography, by place. It is not an individual phenomenon. So the term social determinants of health is truly a geographic community level phenomenon, like a food desert. And that, of course, leads to a higher prevalence of individuals who experience social needs like food insecurity, in the case of Michelle. The reason, of course, those food deserts are there is not by happenstance or by some sort of twist of fate that somehow a food desert's there, or by any stretch of the imagination that patients are somehow willingly kind of moving to places that have less food. Food deserts are there because of policy choices that have been made for many, many decades. Those policy choices are themselves manifestations of structural determinants or structural drivers of health inequity. So food deserts are largely there because of various forms of redlining, which is a form of structural racism. We have to get more rigorous and more clear as we talk about social factors and understand the difference between social needs, social determinants, which is a community phenomenon, and structural determinants. This is important because, as we have seen in our learning collaborative, this understanding helps to unlock the possibilities of how to act. Before I talk about how to act really quickly, let me kind of just pause, look at the chat, see if there's any questions or comments. Great, Megan, thank you so much. Absolutely agree with your statement there, and hopefully what I share today is an indication of at least how some of the teams in Virginia are starting to address this with our support. But encourage everybody, including Megan, thank you so much for kind of modeling that. Please feel free to put stuff in the chat. I'll check in from time to time to make sure that I'm able to kind of elevate your comments or your questions. Before I talk about how to act on this in a minute, let me talk about why it matters here to really underscore this. And I'll come back, Nola, to the slide. Let me go back to the case really quickly, just for Nola's benefit. This is the case for Michelle. And I'll come back to this, Nola. Thanks for your comment there in a second here. But let me kind of focus on why this matters and really kind of unpack this, because before we can act on this, we have to get on the same page about what it is, what the problem is in the first place, how we define it. So what we know is there's a lot of research, not just about maternal mortality, maternal health outcomes in general within Virginia, but across the US and across the world. There was a seminal report that was published by the Commonwealth Fund last year looking at maternal mortality and maternity care in the US compared to 10 other developed countries in the world. And one of the things they found, as you can see on the right, is that around 1 in 3 of US pregnancy-related deaths occurred during pregnancy. There's a breakdown there of when those deaths occur. In particular, 17% occurring on the day of delivery, over half occurring after delivery or postpartum. In Virginia in particular, we know Black women are more than twice as likely to die from pregnancy-related causes as compared to white women. I mean, I want to pause on that for a second. That, as many of you know, is a shocking statistic, one that we should not be complacent in describing, even in passing. Black women in Virginia are more than twice as likely to die from pregnancy-related causes as compared to white women. And the majority of those pregnancy-associated deaths in Virginia occur more than 43 days after a pregnancy. So with this in mind, what are, in the context of moving upstream and talking about social factors, how does this matter? To describe why it matters, let me anchor us to the North Star that many of us have for healthcare, and that's the quadruple aim. You're all probably familiar with the triple aim, or maybe even the quadruple aim now, but the triple aim, as the IHI and others have popularized, is improving patient experience, as you can see on the left, improving outcomes for populations of patients, which includes also decreasing disparities among those populations, and also trying to lower per capita costs of care and improve appropriate spending. That's on the right. The fourth aim of provider experience is increasingly being considered, again, the fourth aim, the quadruple aim, which is making sure that the workforce, clinicians, care teams that are providing this care are also themselves resilient and have joy at work and not burning out. Because if you don't have happy and resilient caregivers and those who are with the appropriate skills and necessary kind of passion for the work or joy, you're not going to get as great outcomes. This quadruple aim is important, but it's not as important as the deeper sea of blue here behind this, which is the consideration of equity. When we talk about the North Star, we make clear that equity matters to each one of these four aims, but it's also an aim unto itself, which is why you see equity displayed here as something that underlies all of these, but also exists outside of even healthcare as quadruple aim, in terms of how it manifests in the community. But this is our description of the North Star, right? Many of us these days are looking at quadruple aim, plus of course more focused on health equity within and across these aims. With that in mind, to make the case about why it matters, let's think about the statistics that I just shared on the previous slide about maternal mortality rates across the US and look into what that research describes as the reasons for the difference. The difference in particular in terms of what we're seeing between the US and other places. And this is true even within the US for when we see differences. One reason for the difference in maternal mortality between the US and peer countries and between states that have better outcomes versus states that don't is the provider shortage. There's a shortage in general of maternity care providers, especially as the Commonwealth Fund described, especially midwives. Midwifery-led care, according to the evidence and the research for women with healthy pregnancies, tends to emphasize more than traditional allopathic care or obstetric care in the US at least. Midwifery-led care tends to emphasize attending to social and personal needs of the mother, the baby, and the family. And the systematic evidence reviews indicate that these models provide care that's at least comparable, if not in some cases even better than quality of care provided by OB-GYNs. That's an important statement here, and this is me stating what the Commonwealth Fund in its extensive literature review across the world has actually identified. So provider shortage is an issue. And this is important in part because the providers here, in this case, midwives, have demonstrated comparable outcomes, if not better in some cases, because they're attending to the social and personal needs. That's an important point here about why social factors matter. It's part of the reason that other countries are faring better is because they have models of care, including staffing models, that are attentive to the social and personal needs explicitly. Another reason for the difference is because of home visits. Home visits, the evidence strongly suggests that home visits by a midwife or a nurse are associated with improved mental health and breastfeeding outcomes, as well as reduced healthcare costs for birthing people and their families. Home visits give providers an opportunity to address the mental health concerns of patients, but it also allows them, again, I'm putting this in bold, allows them to assess the social needs, including needs for food, housing, financial security, protection from domestic or intimate partner violence. In other words, the home visit gives an insight into what's happening in the home in ways that traditional clinic-based care models just don't or can't do well. And so part of the reason that other countries are faring better is because they're providing home visits. And again, part of the reason those home visits make a difference is because we're getting insights into the social needs of patients. And all countries, apart from the US, guarantee at least one such visit within 1 week postpartum, although of course, some states provide for these Medicaid beneficiaries. I know in March, and perhaps some of you can give me an update about this. I know in March of this year, Virginia submitted an application to the feds to extend health coverage to women with incomes below the 200% of the federal poverty level from 60 days to 12 months postpartum to be able to provide these types of supports. So home visits clearly are recognized as an important intervention, and in part that's because their impact is driven by the ability to assess and help address social needs for moms. Another big thing that explains the difference, as again, the Commonwealth Fund and other researchers have well identified, is that social policy, not just social needs, understanding social needs for individuals, but social policy for a whole population actually saves lives. We know this for a fact, looking at the evidence when we look at states that have expanded Medicaid versus states that haven't. Women in Medicaid expansion states, post-Affordable Care Act, experienced 7 fewer maternal deaths per 100,000 live births as compared to women in non-expansion states. This is particularly pronounced among Black women in states that expanded Medicaid, who experienced 16 fewer deaths per 100,000 live births compared to those Black women living in non-expansion states. The expansion of Medicaid coverage saved lives. And the decline in infant mortality in particular was more than 50% greater in those states that expanded Medicaid compared to those that didn't. And again, the declines in mortality were most significant among Black infants. What does it mean when not just the ability to identify social needs like food and housing, but the ability to implement social policy through public benefits programs like Medicaid literally show that we can use this as a way to improve outcomes, including help decrease inequities? The evidence is in. There's a strong base to support that these programs help. And it's also clear, though, that not just social policy writ large, like expanding Medicaid, but social programs, things that address the social needs of individual patients and address community-level social determinants can also help. We've seen that there's evidence to suggest that targeted outreach to patients with high social needs, for example, patients who are low income, who have lower education levels, and who come from historically marginalized communities. The evidence suggests that targeted outreach to those patients in particular who have identified social needs, high levels of social needs, may help increase first trimester entry into prenatal care. This is a quote from a study that you see linked here. Maternal enrollment in WIC exhibited a protective association against late or no prenatal care utilization. Just to translate that, enrolling in WIC was associated with a protective association. Being enrolled in WIC meant less likelihood of not having appropriate prenatal care or having prenatal care too late. The ability to look at social policy and social programs, especially those that address social needs, is critically important, especially if we think about the quadruple aim. Payers are recognizing this across the country, including in Virginia. That's why payers are spending more and more money investing into social programs, social care, as they're calling them, programs that address social needs, to identify these needs and then to address them. You can see, for example, in the bottom, the rise of medically tailored meals, even where insurance companies are literally underwriting the cost of providing food to certain patients, especially who have high risk of hospitalization or admissions. So if payers are caring about this, it means that it matters to the quadruple aim. You're seeing this in particular, not too far away from where you guys are based right now, with health plans that have partnered with local nonprofits to provide those meals, especially to help improve outcomes for pregnant women. And so the idea of home delivered meals is now starting to pick up, especially from the insurers, because they realize the benefits to quality and to costs for patients. It also matters because of burnout. Studies like this one from several years ago are starting to demonstrate the association between the capacity of a healthcare system and more specifically a practice to understand and address social needs of patients, and the link to burnout among the caregivers. In this case, a study of physicians, family physicians across the US, demonstrated that one of the strongest associations with burnout was whether the physicians perceived that the clinics had the ability to address patient social needs. If you're a provider who sees day in, day out women coming in or birthing people coming in with food insecurity, but you have no means to actually connect them to a resource in the community, you're more likely to experience moral injury as a provider because of the inability that you have to be able to help that patient with clearly a health-related social need that is harming their health. That undermines professionalism, undermines a sense of moral commitment, and in some cases undermines the very oath that caregivers have made to help care for their patients. Research is indicating that one of the drivers, not the only, but one of the drivers for burnout, even pre-pandemic, was the ability of a clinic, not just a provider, but a whole team, to be able to assess and address social needs. So there's a lot here that I've tried to lay out here about making the case for why this matters, but this is why it matters. Before we talk about how we act on this, we have to in our learning collaborative, really spent a lot of time thinking about grounding a common understanding of why this work matters. Because if we see it as a side project, if we see social care integration moving upstream as yet another project, we will fail. Because unless we see this as transformational work, not unlike what it means to integrate behavioral health or to turn on and digitize your records and turn on an electronic health record, it's not a project. The whole operation has to start to think about how to advance an understanding of these social factors. When you approach it like a transformation project rather than just a transformation campaign, rather than a simple project, then we start to see improvements, and health systems across the country are demonstrating this right now as they move upstream. And this is important because more than ever, moving upstream is a means to be able to advance health equity, both because of the social needs that I described, but also because there are growing demands on health systems, including in Virginia, especially nonprofit ones, to be able to articulate their role as healthcare professionals. What's our role in being able to improve broader social determinants of health, and even help to acknowledge, if not to dismantle, structural racism as well. These are calls that are emergent across the country, and rightly so. Moving upstream is a way to start to be able to understand how to rise up to that moment, to this challenge, and say, yes, we know we can improve health equity in part by addressing the social and the structural drivers. This is important because to acknowledge, while also acknowledging that many of us don't have the training or the support to do this work well. And that's the work of Health Begins. That's the work of many organizations across the country. And it's definitely the work of this maternal health upstream learning collaborative. When we are talking about how to do this now, let me finish by kind of just talking about a couple of concrete things and encourage the chats to keep on going back and forth. So please feel free to respond to each other in the chat, and I'll pause in about 10 minutes to take questions. So let's talk about not just why it matters, but how to do this work. So first, moving upstream means something very specific. And I want to start by saying it's not just an approach that we take, it's a shift in paradigm. And to help underscore that point and the way in which our teams in a learning collaborative are understanding this, let me kind of share this adage. Give a man a fish and you feed him for a day, teach a man a fish and you feed him for a lifetime. Many of you have heard this, I'm sure. It's an age-old adage. Some ascribe it to an ancient Chinese proverb. Using the chat, can you all kind of tell me if you've heard this? Just a thumbs up or +1 or yes, just to see if you're still there in the chat. Or great, Megan, thank you. Just let us know if you've heard this before. Great. This is a popular, it's an adage, it's something that it's an axiom really, you know, give a man a fish, teach a man a fish. But I'm gonna now show you what it's like to actually challenge the paradigm. Why not teach a woman to fish? What if the pond close to home is polluted? What if she and her family have been historically denied access to resources to fish, like access to rods, tackle, permits to fish in that pond? The point is, in our approach and things that we consider to be so foundational in terms of the way to see the world about what it takes to improve outcomes, we're so used to seeing this idea of give a man a fish, it helps a little bit, but teach, and you feed him for a lifetime. In other words, we're focused on the behavioral levers. Like if we just improve the knowledge and the behaviors of the individual, he will feed for a lifetime. But what's missing from this adage is a structural analysis, is the ability to recognize that in many cases, many of our programs, and the patients that we serve are operating on an uneven playing field and operating in an environment where the structures, the systems that they're operating on are literally working against them. Where would you like to be on this playing field? Would you especially if you're somebody who's on the bottom of this playing field, you probably are aware of it because you see the speed of the ball coming towards you, you see the difficulty of kicking the ball back up the field, of engaging in this particular game. But if you're someone who is on that field and you don't even know that the field is uneven, if, for example, you've bought into the give a man a fish, teach a man a fish, without challenging the fact that there is a deeper structural reality behind that adage that we have to challenge and understand, you might be even worse off because you're on the field and expending energy in a wasteful way, right? Not necessarily understanding that the odds are stacked against us. We have to start to shift our mindset towards a structural analysis in our work. This is particularly important for us as healthcare providers. I'm a physician myself. I'm a tertiary prevention downstream provider, right? I take care of patients when they're sick. I operate, as with many of you, in thinking about the programs that we provide to specific patients. That analysis is necessary. That's an important, obviously vital body of work. But sometimes, especially in the dominant kind of way we think about things in the US, including in our professions, we sometimes tend to, we sometimes miss the opportunity to really apply a structural analysis to the problems that we see in front of us, and then end up throwing more programs at what needs to be actually more systemic solutions. Moving upstream is not just about an approach that I'm going to talk you through in a minute, but it's really about shifting in mindset, challenging ourselves and our colleagues and the communities in which we live to start to shift away from just describing the effects or the disparities to identifying the inequities, the root causes for those disparities in the first place. It means moving away from reviewing surface level problems and analyzing deeper structures. What's that playing field look like? How uneven is it? It moves away from assuming that behavior change is sufficient for moving outcomes, and instead focuses more on thinking about the systems in which people operate and behave. An example I like to give is, imagine you're in a conference room. This is hard to imagine in COVID times, but imagine you're in a conference room with maybe a boardroom with 12 people, and you're sitting around the table, and then somebody asks you to step outside for a moment. And then when you come back inside, there's only 2 chairs left. One chair is fixed at the head of the table, rooted in there, it's bolted to the ground. Another chair is on wheels. And now the 12 of you are invited to come in now and take part in the meeting. Your behavior will change in that room. Some of you will sit in that fixed chair. Some of you will sit on that remaining chair, but we'll be rolling back and forth. Oh, by the way, we've elevated the floor a little bit so that there's a slant, so that one chair always rolls down. And some of you might need to, of course, stand, and some of you might opt out of the room. And some of you will, my point is that the structure of that meeting, the structure of that room, that space, and the norms of it literally shifts your behavior. So we have to start looking at the systems in which our behaviors manifest, rather than just thinking that behavior change for our patients is sufficient. So this is it's a mindset shift, and it's important, especially when we think about, Michelle, and remember social needs, social determinants, and structural determinants. This is part of understanding. This is why this is an important kind of set of terms. It's not just terminology, it's representative of a shift in mindset, moving towards a structural analysis where we're looking at surface level social needs for individuals, and then the community and the structural factors that drive them. Moving upstream, therefore, means something concrete in this understanding. It means working continuously to improve the social and the structural drivers of health equity at all levels: social needs for individuals, community level social determinants, and broader structural determinants of health. Our teams in the Learning Collaborative have been using this definition to start thinking about how to articulate clear goals then for their work. Clear goals. When you start to unpack this, what are the ways that we can improve outcomes for maternal health outcomes by being able to, as you see here on the right, to lead efforts in our clinics and our hospital systems to improve the screening and the addressing of food insecurity for our patients, as well as other social needs for birthing patients, as well as for our employees, many of whom suffer from the same social needs oftentimes. For the community level social determinants, you might say, well, we're a healthcare system where I'm a clinician, I'm an OB. Is it my job, or can I even do anything about food deserts? The answer is absolutely, because you operate in an institution, and that institution has power, and therefore a responsibility to, if not lead, at least partner. So for example, to partner with local community-based organizations and agencies to help end food deserts, right? To work on that community level social determinant. And then lastly, to also be able to articulate clear goals to support policies that have evidence behind them, including those policies that we know lead to better outcomes, specifically for maternal health. For example, expanding postpartum coverage, expanding home visits, and policies to prevent and even undo redlining to, again, lower the impact of inequities on patients like Michelle. So understanding the structural analysis really leads to concrete definitions of what it means to move upstream, and then that informs clear goals that teams and systems can take to move forward. And the concrete steps to get to this that the Learning Collaborative supports is to go through at a high level a stepwise approach to taking this understanding and putting it into practice. That means identifying priority populations and patterns of inequity within those populations, identifying social drivers of that inequity, again, at all levels, identifying relevant goals based on that, and then pursuing early wins through the development of quality improvement campaigns. Here's another way of kind of depicting those 5 steps here. This is essentially at a high level, the Health Begins upstream approach that we've developed over years working across the country. Here's an example of what it means for Michelle. Let's start with patients like Michelle who reside within a specific place. This is a key part of moving upstream. You have to define not just people, but a place in which they live. So patients like Michelle who reside within, say, 4 census tracts with the highest rates of preventable hospitalizations, the data from VHHA, the data from the health system, from VDH, all these data points become helpful to identify where to target. And then within that place for those people, then identifying the disparities or specifically the racial and ethnic inequities that exist. For example, you might find that Latina and Black pregnant women and postpartum women experience higher rates of hospitalizations compared to white counterparts who live in the same area. Now you've got a pattern of inequity for the population. We've identified a social driver like food insecurity. So we're going to skip that step 2 and say, well, let's look at food insecurity, for example, as I've been talking about so far today. And then we say, well, let's set some clear goals. And so our teams are supported to set really clear goals, including goals, explicit goals to address equity. We give recommendations about how to do that. And the bottom line here is that far too many quality improvement initiatives in hospitals, including those in maternal health and for other conditions as well, set good quality improvement goals for a whole population, but fail to set additional specific equity goals. So you can see an example on the right. There is a team that wants to look at gestational diabetes, hypertension, and preeclampsia among birthing people, and thinks that they want to address social needs. The team would first collect and review their race, ethnicity, language data, identify those inequities, as we talked about in the first step, and then set appropriate QI goals that not only, number one, achieve, for example, can achieve a 20% increase in baseline in prenatal care engagement among all patients, including Black women, but also have an explicit goal to decrease the disparities in the control of their kind of target conditions between Black women and other groups by 40%. In other words, the reduction of the disparity, the reduction of that inequity is an explicit goal. That's a key thing to actually doing health equity work as we're finding across the country and as we're finding in this learning collaborative. Without setting equity as a clear goal, equity will not improve. Last but not least, to kind of briefly here, the upstream approach helps teams to identify ways they can achieve their goals, their equity, including their equity goals, by working across different levels. And we walk teams, including teams that have now partnered with community-based organizations, to identify different opportunities using what we call the 3x3 or the upstream strategy compass. This 3x3 grid identifies, as you can see here, opportunities across levels of prevention on the y-axis, as well as levels of intervention or impact. You know, what does it mean to provide services for individuals? What does it mean to transform the way institutions work? What does it mean to actually start to address policies at a structural level? As clinicians and as healthcare professionals, we tend to only think about and only know about the things in the bottom left of this 3x3 grid. We're most familiar with individual tertiary or secondary prevention opportunities. Public health agencies, community-based organizations, coalitions, policymakers are more familiar with opportunities that may exist towards the top right. And this is a key part of moving upstream when you have a defined population and defined place. Partners can come together and identify the very different opportunities across levels of prevention and across levels of impact to be able to move upstream. That's important because finally, with teams, they start to identify early wins where they can lead, partner, and support, and conversely, where their community-based partners or public health agency partners can themselves lead, partner, and support. And as they select their portfolio of early wins, these then get advanced through quality improvement campaigns. Quality improvement project charter, that's what teams are developing right now, the Learning Collaborative. Project charters that have specific aims statements with clear kind of projects, charter kind of elements outlined for the projects that they're going to lead, as well as projects that they can partner and support. Through that upstream quality improvement approach, this approach that now understands what it means to move across all levels and how we can lead, partner, and support, this is how we plan to support teams, or have been supporting teams, I should say, to move upstream there. I'm going to pause here because I think I'm at time. I'm hoping this was helpful for you all to understand at least the Maternal Health Upstream Learning Collaborative. If there's anybody who has questions about the work we do, I'll put my email in the chat as well as the email of my colleagues. And thank you again for all of your time. Shannon, I'll turn it to you.
Thank you very much. Let me see if we have any questions. I do want to open it up to Allison real quick at VHHA. She wants to give a little bit of a further in-depth discussion or comment about the Maternal Health Collaborative. Allison, are you?
Yep, I'm here. Can y'all hear me?
Yes.
Okay. Hi, everyone. As Shannon said, my name is Allison Hicks. I am the Maternal Health Program Manager at Virginia Hospital and Healthcare Association. Rishi already said all the important stuff. Thank you so much, Rishi, for that wonderful presentation. Your guidance here is so valuable to us. But I just wanted to quickly say that we are starting to look for participants for grant year 2. We'll be starting kind of mid-2022 with that, but I'm always happy to talk about it, happy to answer any questions. I'm going to put my contact information in the chat as well, just in case anybody wants to talk further about that. That's all I have. Back to you, Shannon.
Thank you, Allison. So for those of you, I know sometimes it's hard to pull out of the chat, and we are at the end of this presentation. So I will make sure that any emails that were shared throughout the last 2 days, I will make sure that it is in an email, a summarized email that will go out to everybody later this week, especially when I have the YouTube links for all the presentations uploaded. Kim, food insecurities includes lack of, just a more further explanation about food insecurities. Thank you, Kim. And Dr. Manchada, you're a very insightful and gifted speaker. Thank you. Trying to catch up with some of the chats. Again,
I just to help you out with that as well. I saw Katie, thank you for your comment about the midwives as well, and the specific opportunities there to improve parity in the fee schedule. Kristen, thank you for your kind words, as well as what you shared earlier in the chat about the need for education in the emergency departments. Absolutely, that's an intervention point, especially to identify social needs and to help address them. And then I think we addressed some of the other comments earlier. So thanks, Shannon.
Yeah, thank you very much. Again, for all the speakers that are still on, first of all, I want to say a big grateful thank you. This summit would not have been successful without your presentations. And truly, it takes a collaboration and a group for all of us to really pull something like this off. So I was just merely the agenda writer and the facilitator. It was really the wealth of information and passion that it just screams from all of everybody's presentations. I want to make sure, Donald, are you on? Do you have anything you want to say to close out today? And he may be rounding because I do know he was on service today. So without further ado, I did put the link in the chat. Let me do it again really quick for evaluations. Again, I will share that link with an email, but we really do. I read every single comment, and I hope that you find that each year it is getting better and better. And that is the only way we can truly improve, is through evaluations, comments. And I'm happy to hear any suggestions on way to improve, but if you could please provide ways to improve or way we can make this better, that's how we can in turn come back and do this again and again each year. So again, thank you everybody for being here. And we'll turn it over and say, have a good afternoon. Bye, everybody.